วันนี้เดือดโอเคประมาณ क्या रिमूवेबल नाम के साथ?
Hi, Rajesh.
Hello, sir.
Hello, good morning.
Hello, good morning. Good morning.
Rename. So all set?
Good morning, everyone. Am I audible? Hmm? Hey, video on है?
Hello, hello.
Good morning. Am I audible?
Yes, Neha.
Good morning, everyone. I'm Dr. Neha Khere, and I would like to welcome all of you on behalf of KM Shah Dental College and Hospital and Sumandeep Vidyapeeth to the 18th edition of Prakritrim, our continuing prosthodontic education program. See, as human beings, all of us have an inherent nature to yearn to learn. And this yearning brings us here today to focus on the heart of cutting-edge technology in dental implants, that is, the implant abutment. But before we begin, we must seek the blessings of Goddess Saraswati and let us ask her to bless us in the pursuit of knowledge.
सरस्वती नमस्तुभ्यं वरदे कामरूपिणि विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा।
May I now request our enthusiastic and dynamic head of the department, Dr. Rajesh Sethuraman, to please welcome everybody. Thank you, sir.
Right. Thank you so much. I hope I'm audible enough. Right. At the outset, when we always do plan for thinking about a topic in prosthodontics, implants always happens to be something that is very dear to every practicing surgeon, every practicing prosthodontist, every practicing dentist per se. But then when the patient does come to us, we all do know that they come to us for teeth and not just for the source on which the teeth is going to be placed. And that has how signified the significance of prosthetically driven implantology. And selection of abutment in that happens to be a very, 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 very important role that it got to play. Of course, we had this particular program well in mind. We often wanted to have it as a physical meet, but then because of certain administrative constraints, we had to resort to the online mode. Of course, Zoom has helped us a lot in getting people together. And that's how today we are here to understand and listen about abutments in implant prosthodontics from two of my great friends, Dr. Praveen and Dr. Harsh. They both were so good enough to consent within just a phone call to tell, yes, we shall be there for you, Rajesh. We shall be there for prosthodontics. We shall be there for implantology. I thank them from the bottom of my heart for having consented and being there in present right from the morning, even though it's a working day today. Of course, my heartfelt thanks goes to also my dean, Dr. Subramaniam sir, who has immediately consented and said always yes for prosthodontics, the department. And when it comes to me, of course, I get it directly from sir and I take a little liberty from him. And he has never said no to this department. Thank you so much, sir, for always being there as a strong support for the institution and prosthodontics for sure. On behalf of this particular department, I welcome all the delegates, all my heads of the department of the different departments of KM Shah Dental College and Hospital, and also of Prosthodontics Gujarat. For all of them who have registered in such large numbers that we decided that we may also have to go YouTube live so that everyone gets amply benefited by this particular program. And then thank you so much, Praveen and Harsh. And we would see to it that we make the best out of your knowledge and expertise in this particular subject. Thank you. Thanks a lot.
Thank you, sir. I would now request our zestful paraclete, our Dean Sir, Dr. R.V. Subramaniam, to please address the audience.
Very, very good morning to all of you. I hope all of you are able to hear me.
Yes, sir.
First and foremost, I would like to congratulate the Department of Prosthodontics, Dr. Rajesh and his entire team for thinking of organizing such a webinar on such an important topic. And naturally, I also have to thank Dr. Harshvardhan Arya and Dr. Praveen Kumar Patel, who, I've been very kind enough to immediately agree for this particular program. That too, I think at a very short notice. Thank you, Dr. Harsh and Dr. Praveen. Very kind of you. Okay. Is it morning or afternoon in Malaysia?
It's afternoon now, sir.
Okay.
2.5 hours.
Okay.
12:30 almost now. Yes.
So once again,
morning.
thank you so much. Of course, I'm not much aware about implants. Forget about abutments in implants. Okay, being an oral pathologist, probably I'll be more concerned about peri-implantitis rather than the role of implants or abutments in implants. But of course, the only thing good about implants is that our college is earning a lot, thanks to the three departments: oral surgery, periodontics, or rather periodontology and prosthodontics, who are doing wonderful work on implants. And here I would like to state that the past 1.5 years or so, ever since the prosthodontia department has started working in the implantology department, maximum number of cases are being done by prosthodontics. So I'm really thankful to them, and I'm sure this particular topic will be of great use to all the participants who have been nice enough to register for this webinar. So thank you all. Once again, thank you so much. And I hope there is a wonderful scientific deliberation today. Thank you.
Thank you so much, sir. I would now like to introduce our first speaker of the day, Dr. Praveen Kumar Patil. He's currently working as Associate Dean at IMU School of Dentistry, Kuala Lumpur. He is Implant Research Cluster Head and Implant Clinic Lead in IMU University. He is an examiner for 2 international exams by RCS Edinburgh and ITI Diploma in Implant Dentistry. He is ITI Research Committee member and adjunct professor in 3 premier dental institutions in India. He is member of Council for Prosthodontic Research by Indian Prosthodontic Society and Intellectual Property Committee of IMU University. He is also editorial board member of the JPD, associate editor-in-chief of IJOPRD and academic editor of +1 IJD and case reports in dentistry. He has also secured several grants, published over 160 articles and reviewed over 350. His research focus areas are implant over dentures, abutments, prosthetic designs, and complications. May I now welcome Dr. Praveen Kumar, sir. Please take over, sir.
A very good morning, Dr. Neha, and thank you very much for kind introduction. A very good morning to everyone, Dean Sir, Rajesh Sir, Harsh Sir. It's been pleasure here to be almost back after, I think in 2019, I was there in one of the IPS conference organized by the Gujarat branch. Thank you very much. Let me just share my screen first. My screen is visible now. Is the screen visible?
Yes, sir, it is.
Okay, perfect. Yep. So let's begin. Thank you very much, everyone. And I'm talking on the abutment in implant prosthodontics. Thank you, Rajesh sir, for this kind of opportunity. And I will try to share my little bit of experience in implant prosthodontics regarding their selection criteria, types, materials, aspects, and complications. Okay, this presentation comes from a vibrant city of Kuala Lumpur, and our university is located in southern part of Kuala Lumpur, on the way towards the airport. And yeah, I work here. Most of our implant clinics are being practiced in these clinics, and then we do have a postgrad diploma in implant dentistry where uh, most of my work is coming from there while supervising the postgrad students in implant dentistry diploma and my own faculty practice patients. Well, so today's learning outcomes are abutment selection criteria in implant fix and removal prosthodontics, design materials, applications, and mix of implant abutments, and implant complications due to non-original abutments and their management strategies. Let's begin with the first case, and when we have such case, compromise, we definitely can look into the limited space for the prosthesis, and one must also appreciate that there are some degree of bone loss on the labial aspect and a little bit of mesial migration of right central incisor and left lateral incisor and so many things. Uh, to me, though it's a straightforward in terms of a little bit of space management, the amount of soft tissue which has lost from the labial aspect is the important criteria which makes this case from straightforward to almost more the advanced or complex one. So look at this now. So implant has been placed in this compromised bone volume, and the abutment has to go there anyway to manage this while replacing the edentulous space there. Now, when we talk about the management of these edentulous spaces in aesthetic zones, abutment plays a very critical role. And these types of abutments, when you look at it, when the something black in color, something metallic in color is coming out of the gums, I would say, it's not just about the masking the edentulous space, but it's just also about the giving it a aesthetic concern in terms of how much amount of metallic hue is popping out through, especially in the region where you can see the area where the metallic components are coming out of the gingiva, and maybe probably give it a little bit of a bluish hue or not. Based on that, we can consider this case as a bit of complex one. Of course, we do have a lot of managing strategies in terms, though no matter whether implant has been placed in a compromised position, we do have something to mask it with the pink porcelain. Sometimes patient may not happy with the open embrasures and then need to cover it a bit more along with the pink porcelain, and then there is a lot of other issues in terms of maintaining the peri-implant tissues and maintaining the peri-implant health and cleanliness. So from the beginning, though you as a prosthodontist have done a great job camouflaging the aesthetic aspects of these patients, and when you look at their replacements and patient is fine with it, there are a lot of tissues. There are a lot of issues where you have to take care of it. And first come first is the maintenance, and the big problem is the wrong case selection or wrong treatment planning. In that case, definitely one must have placed the implant in a right position, respecting some tissue loss by doing some bone grafting and soft tissue grafting procedures, and then taking up the case for placing the implant to give a aesthetically more pleasing appearance for the implant abutments. So it's not just in prosthesis which will make your life easier is a lot has been depending upon the treatment planning stage, where at what position and what angulation your implant is being incorporated in your bone. Well, no matter whether patient is happy or not, there are two aspects of aesthetic zone. Objectively, one must be defining that the aesthetic zone is in any dentoalveolar segment that is visible upon the full smile, and that's where the people perceive this aesthetic zone. But there is another angle from the patient's perspective, or the other side of the ball is the subjective perception from the patient's point of view. And if any dentoalveolar area of aesthetic importance for the patient per se. So for this case particularly, even though uh, from prosthetic dentist point of view, even though it's not greatly been camouflaged well, but if patient is happy, that's an aesthetic success. So patient's aesthetic expectations play a very critical role in implant dentistry, and that can be respected in terms of your aesthetic evaluation. So look at the second case now, and this has been definitely given a bit of more predictable chance for replacement of teeth, and simply because there is a good big volume of root which has been still in mouth, and that is where the amount of bone volume has been preserved well with this unrestorable tooth structure. And the root piece, which even though it has been indicated for extraction, sometimes maybe you can think of some other treatment options by providing some uh, preventive strategy or restorative strategies by giving post and core and crown or crown lengthening and so on. And those aspects where you have a case which has been indicated for extraction and need to plan for implant restoration. Now, in this particular case, you have a little bit of a safe zone. In a way, your bone volume has been maintained with the root which is there. And if you want to place the implant in this particular cases, uh, rather they are a little bit easier than the one which we have seen earlier. And in these cases also, the implant placement comes to a very important aspect in implant treatment strategies and overall success. I was there in last month in ITI World Symposium, and Nicola Zitman, one of the professors in prosthodontics, was talking about this ideal prosthetic designs. And definitely this prosthetic designs, when you place the crown into a mouth, then you can determine the actual position of implants. And that's where Rajesh sir was also talking about the prosthetic driven implantology. And so it's all becomes like a backward treatment planning, I would say. You place the crown, that's where your digital implant planning and guided surgeries comes from. So you place the crown first and then plan the implant position, no matter how much of bone amount and how much of the shape of bone has been remaining in mouth. Now you place a crown in ideal position first, and then when you plan the implant position to make up these adjustments, then you can think of whether you need some bone grafting, whether you need some repositioning, whether you need some orthodontic adjustments, whether you need some osseous distraction procedures, whether you need some adjustments of sizes of implants, whether you need from selection of type of abutments. And that's all about the overall success of these implant treatments comes from. Well, so when we talk about the successful implant treatment, which comes, of course, to support the abutment, that's all comes from the root of the tooth first, yeah, and that's the implant positioning. It's all about the soft tissues which are surrounding these implant restorations. And when you talk about the soft tissues, we talk about the peri-implant bone volume and bone level. So there are two aspects of this bone level. One is when you look from front, it is the interdental bone level. And then when you see from the lateral side is the facial bone thickness, which matters a lot in overall aesthetic appearance as well as overall functioning of these types of implant supported prosthesis. Booster has predictably given a very good guidelines in this particular article, 2004. So when you talk about the implant predictability, implant treatment success, we talk about the surgical considerations of the planning and execution, patient selection, implant positioning, and soft tissue stability. So I'm coming towards my main topic of selection of abutments and criteria of abutment selection. What matters most here is implant positioning and assuming that abutments will work best when you place the implant in the most ideal position. In a way, in another language, when you place abutment first and then plan implant position, then your strategies needs to be changed for placement of these implants. And if you have few more prosthetic abutment options in hand, then you can tweak around your treatment planning a bit. And that's what we are learning today while understanding different types of abutments and different strategies for selection of these types of abutments in managing such cases. So by definition, these abutments serves as a support or a retention for a dental prosthesis. It is also a link between the implant and the prosthesis. It provides a prosthodontic platform similar to that of the tooth restoration. Well, so when we talk about the abutment, we talk about not just the abutment which is resting on the implant, but there are a lot many junctions, there are a lot many connections, there are a lot many contacts, there are a lot many contours, and that whole science needs to be revamped and reach to understand the overall treatment outcome for these implant restorations. In principle, there are typically, let me just disable the hanging, floating, hide floating. Okay. So in principle, when you talk about the implant restorations, of course, this is a fully edentulous case where the upper three photographs are about one type of implant abutments. So these, whatever metallic rods are coming out, of course, these are the abutments which are being supported with the implants underneath the bone. And not all abutments needs to be parallel because not all implants have been placed parallel because of the bony topography and so on. So these all anatomical limitations, all anatomical information, bone volume and shape and topography will dictate, at up to certain extent will dictate this implant positioning, and then prosthetic abutment needs to play a adjunct role in managing this little bit of compromise or offline or off-angulated implant placement by inherent nature of this implant abutment design categories. And if your implant has been landed up in placing in a bit of a lateral angulation, then you probably have to choose the angled abutment. So that's how the different categories are coming from. And then slowly, we will start understanding these design aspects. So when top three images are considered to be one of the base implant prosthesis category, which are typically known as a cement retained prosthesis. The bottom three images are about the screw retained prosthesis. We'll talk a little bit more about these two types, which is very important to understand why you should be having both options open, why these two designs are there for, even though the foundation or edentulous arch is more or less same. Yeah. So number one, when you talk about the edentulous arch or any partially dentate arch as well, when you place an implant down there, there is a issue that these attachments, basically the abutments are basically connections which are being placed or screwed into the implant underneath. Well, so when you understand these two types of prosthesis, the cement retained prosthesis is the one which is having a separate abutments which are popping out of the gingiva and of course from the bony level. And then the whole of the prosthesis will be cemented back. It's like a same like a crown preparations, multiple crown preparations, and then you are giving a cementing the bridge on top of it. The second category, the bottom three pictures are about the screw return processes, and that's where the implantology plays a very crucial role. One of the famous option, I would say, the screw return processes, and these screw return abutments are basically where the abutment, the platforms are there in which are there as a part of the implant, inherent part of the implant. Sometimes due to the multi-unit abutments, there could be an intermediate part for the abutments to change the angulation. We'll talk a bit more about that later on. But the whole of the processes will be incorporating these abutments inside the prosthesis, and the whole prosthesis will be screwed in. So in top order, when individual abutments are in place in the implant, then you can screw in those separate abutments first, and then you cementing the whole prosthesis. In the bottom part, the whole prosthesis can be screwed in together. So there is a problem when you expect the full arch restorations, or for that matter, long span restorations, to be screwed down, which has been a single unit, which you want to screw in onto the multiple implants. There is always a possibility that this prosthesis needs to be 100% perfect without single micron of error. Then only you can achieve the passive fit for those prostheses, which can be nicely been screwed in onto the existing implants. And that's next to impossible, because there is no such prosthesis exists which has got 100% of accuracy till date. Yeah, so there will be few microns of errors, and when you try to tighten this whole of a single unit prosthesis onto multiple separate implants, there is always incorporating some nature of stresses. When you tighten the screw, there will be a few amount of stresses which are being incorporated into the implants, and that's where the downside of these types of restorations. But most of these implant restorations are all about the screw return prosthesis, and there is only one advantage about this restoration, is that you can easily retrieve these types of restorations because you have a screw access channel which can straightaway take you from here to the so the screw access channel is coming where the whole of the prosthesis can be screwed in onto the separate implants. And imagine when you are tightening the screws between 20 to 35 Newton centimeter of a torque for all these implant screw holes directly onto these separate implants. Imagine your prosthesis needs to be 100% accurate, and if it is not, then you are incorporating the excessive stresses, and if there are stresses, there is a bone loss. So that's how the vicious cycle goes on, and then everybody is only working on how to improve the accuracy of these types of restorations in terms of prosthetic planning and prosthetic restorations and lab procedures. Well, so we will also discuss a bit of difference between these cement return processes and screw return processes. But I'll go back and then talk about this cement return processes. One of the best part of these types of prosthesis is that no matter at what angulation your implant is, you can put some angulated abutments or straight abutments, and then you can screw it separately. That's one way, and then try to prepare all these abutments with the straight path of insertion, and then fabricate a separate cement return restoration which can be cemented on these different implant angulations. So advantage over the screw return prosthesis to the cement return prosthesis is that the cement return prosthesis will be having or incorporating less stresses onto the implants, because there is no question you are not tightening the whole single unit onto the implants. You are simply cementing that whole prosthesis onto multiple abutments. So cement return prosthesis in a way is not giving you excessive stresses, which the screw return prosthesis is giving it. The other good advantage, or of course, the other advantage of the cement return process is that no matter at what angulation your implant has been placed in the bone due to the bony anatomy, your implant angulations can be managed. The abutments are separately being installed onto the implants, and then the cement return processes do not have any single abutment screw access channel onto the surfaces, onto label surfaces, occlusal surface, or even a lingual surfaces. However, on the screw return prosthesis, you will always be having some screw access channels, which may not be always coming onto the lingual side or occlusal side, but sometimes it may come onto the facial side. So that's where these abutment selection criteria plays a very important role, and that's what we are learning today now. So when it comes back to the types of abutments, I would categorize those into four basic categories. Number one of course, this is whether it's a screw retained or cement retained abutment, but whether it is engaging and non-engaging abutment. Now, when you look at the engaging abutment in general are for single implant restorations or for 2 or 3 implant restorations, but whereas short span restorations which do have a relatively parallel implant parallelism. Those implants, especially when you look at the completely edentulous cases or multiple implant restorations in long span partially edentulous cases, your abutment needs to be don't have to be engaged onto the implant collar as this way. Yeah, so non-engaging abutment has its own role, because if imagine you have 4 to 5 implants with a different angulations and you are engaging the whole of these notches inside the implant. Imagine if you want to take out the whole prosthesis, it's not possible to take out the whole prosthesis, because every different angulation has its own engagements and its own hex positive and negative replica, which is precisely fit inside, and that's where the basic part. So when we come down to the multiple unit abutments, they are usually non-engaging abutments. So that's one big difference you need to understand first. The second category comes down to the customized abutments. Now, first category is all about the prefabricated, pre-milled or prefabricated abutments or stock abutments, I would say. The second category, of course, is a milled category or customized abutment category. It can be milled out of the titanium. It can be milled out of the zirconia. And Dr. Harsh, sir, will touch upon a bit more about this in detail, about the customized implant abutments. The third category, I would say, one of the most widely practiced nowadays is taking advantage of metallic titanium base, which is prefabricated, pre-machined. So your abutment onto the metal implant will be settling down with the metal connections, which are machined ones, and that is typically known as a titanium base abutments. Now, these titanium bases are being separately stuck together with the CAD/CAM zirconia abutments or CAD/CAM milled restorations or any other types of metal ceramic restorations. So, but the important part of these types of abutment is that the machined titanium base must be engaging the implant collar first. Then the top part can be stick together, and there is a procedure to stick this separately casted or separately milled tooth color abutments onto the titanium bases. And of course, the fourth category is a temporary abutments, which are used for a specific reasons, usually in aesthetic zone, to maintain the bone volume, to maintain the shape of the chinchava, to maintain the shape of the soft tissues. And the soft tissue or temporary abutments we'll talk a little bit later on at this. So number one is whether engaged abutments or non-engaged abutments. Number two is customized milled metallic or zirconia abutments. Number three is titanium base abutments, and then the number four is the temporary abutments. So when you look at these types of abutments, the cement retained restoration, the crown will be cemented separately onto the abutment, and that becomes your 3-tier system, where implant is a separate portion, abutment will screw in separately, and then the crown will be cemented separately. However, the screw retained prosthesis is a 2-tier system, where implant is another 1 tier, and the abutment and the crown becomes the single unit, unlike your cement retained prosthesis. So when you screw in the abutment, there is always a space for screwing this screw retained prosthesis, there is always a access screw hole or screw access hole, which is popping out parallel to the long axis of the implant. And if that's the tricky part of the screw retained prosthesis, but one of the most widely used type of restoration. And then the third category, where the implant and abutment becomes one part or one segment or one portion, and then the crown will be cemented separately. And that becomes your single piece implants, where your part of the implant screw threads will go into the bone, and the same portion or same part of the implant will be popping out of the chinjaw as well to support the prosthesis, and relatively less scope in implant prosthodontics, where relatively only can be protected for these types of implants or single piece implants for overdentures or sometimes central or lateral incisor missing prosthesis. So this is what I was talking about, the problem of cement retained prosthesis, or sorry, the problem of a screw retained prosthesis. So in this particular case, when you look at the implant positioning, the implant has been placed buccolingually, definitely because of the anatomical nature of the maxilla and the resorption pattern of the maxilla. Surgeon had landed up with the implant placement, little bit of buccally over tipping of these implants, and they are typically known as an compromise or unfavorable positioning angulations of these implants. So when these implants have been placed little bit on labially tilted angulation, your screw access channel is going to be on the labial side of the teeth, and that's where it's difficult to mask this screw access hole with a composite with giving some good aesthetic outcome, and that's where different types of abutments you need to understand now. So when the cement retained abutments comes into a picture, no matter what direction your implant is, you will separately put screwing the abutments and then the cementing the prosthesis, one of the most aesthetic treatment option. But when you come down to screw retained prosthesis, the even though the screw access channel is coming from the labial side or lingual side or occlusal surface, the retrievability is the biggest advantage for the screw retained prosthesis. That means if something goes wrong with this type of prosthesis, imagine if one of the implant has been having some peri-implant problem, and then you want to take out the whole prosthesis, which is actually cemented onto these multiple implants, and one of the implant is giving some pain or some inflammation or some bone loss, and you know how to remove it. So cement retained prostheses are very much difficult to remove. On the contrary, when you use the screw retained prosthesis, you have straightaway take out the screw access channel and then unscrew the prosthesis, whole prosthesis will come out. Yeah, so this is what is the basic difference between the cement retained and the screw retained prosthesis. If you see the worldwide prosthetic protocols or practices, most of the clinicians are shifting towards the screw retained prosthesis only because of the retrievability of these types of restorations. Anything goes wrong, you should be able to easily retrieve these types of restorations. And that's where you need to now learn how this, no matter whether implant has been directed on the labial side, how this screw is coming on the lingual side always. So these are the types of abutment which you need to understand now. Before going to those understanding different types of abutments, I will come back to what the literature says about the cement retained and screw retained prosthesis. Definitely, one of the key element of a downside of the cement retained prosthesis is that is very difficult to take out the residual cement, which after cementation, is very difficult to remove the excessive cement from underneath the prosthesis, and that residual cement is always a constant irritant, potential irritant, which will be leading some biological complications. It starts with the peri-implant mucositis and slowly going into the bone loss, causing peri-implantitis. Now, so that's one of the biggest downside of the cement retained prosthesis, though they are in terms of stresses very much passively fitting. in terms of aesthetics, amazingly aesthetic, because there is no question of any screw access hole coming out from any of the surfaces. But the residual cement is the main issue about this, and most of these systematic reviews, when comparing the cement versus screw return prosthesis, indicated that the cement return restorations will be having more biological complications. That means they will be having some more peri-implant problems, peri-implant mucositis and implantitis problems. However, the screw return restorations will be giving you more technical problems. Of course, it's understood, because if you imagine that you have a different types of screw angulations and you tighten it those, and then the whole prosthesis, you have an access screw hole, which has been shifted from labial side to the occlusal side. So you have an angled abutment and so on. And those needs to be taken care a bit more critically, and the abutment screw loosening is a bit more evident in screw return restorations, simply because then if you have a long span bridges also, when you try to tighten all these processes, you won't be able to achieve the passive fit of these restorations, because you are tightening these restorations, the single piece restorations on multiple implants with the screws, which has a little bit of possibility, always a possibility of tightening this screw, giving some excessive stresses onto one or the two implants. And that's where the stresses comes to a picture, giving some more technical problems, and eventually they will definitely cascade down to the biological problems later on. Now, when you talk about the abutments, abutment is basically a prosthesis. One must understand, one must realize that all these abutments should be a part of your natural replacement of teeth. Like Rajesh said in the morning, there are two key statements he has made. One is a prosthetic driven restorations, implant dentistry, and patient comes for the tooth and not for the implant. So the patient do not bother what type of things you are putting in his mouth inside. He bothers only about how he is going to look like, how this space is being replaced with the natural uh, natural appearance, and how this prosthesis is being as close as his previously natural uh, tooth, which has been missing. So it's not only about whether it's a cement written prosthesis or screw written prosthesis, but it's also about how much of aesthetic value is giving when the abutments are coming out of the gingiva. And as you all know, if the abutment itself is white in color, definitely it is going to give you a much more aesthetic value. Even though the gingival thickness is less, but something is coming white in color out of the gums, definitely is not going to change any aesthetic perception here. But imagine if there is a black color or gray color metallic thing coming out of the gingiva, and imagine if the gingival thickness is less than 2 or 3 millimeters, the thin phenotype of gingiva will definitely show up some grayish hue in this. And for some patients, it may not matter because subjectively they are happy, but there are many patients into your practice will come across that they will not like this. Even a slightest blue hue around the gums will be actually something giving them a bit of artificial look, and they are not, probably they are not happy. So a lot of research has been happening around this, and the mucosal thickness is playing very crucial role. So I'll talk a bit more about the mucosal thickness later on, but look at these different types of abutments. By design, they look same, but they have been anodized to look a little bit of yellowish in color. They look a little bit in pinkish in color. And definitely when you evaluate these types of abutment, which type of abutment will give you the most aesthetic value? Yeah, this is very straightforward. A picture will definitely give a more aesthetic value because whiting is coming out of the gingiva. Probably pink and golden color will also give you a little bit of more aesthetic value, but little bit less than the white ceramic or zirconia abutments, but definitely better than the little bit of more grayish hue. That's exactly what this article has published the results and then indicated that Gold anodized or pink anodized titanium abutments achieved better aesthetics for peri-implant soft tissues than the unanodized titanium abutments. Yeah, so that's one way. Of course, and then the zirconia was definitely giving a bit more aesthetic value anyway, as compared with any of these metallic abutments, that's for sure. There is another study, probably the thesis from University of Zurich, indicating that all ceramic crowns on the aluminum based abutments reveal better aesthetic color matching to the neighboring teeth than the PFM restorations. So like I said, no matter where your implant has been placed, no matter how much is the gingival thickness, if you are placing the white color, of course, these are zirconia or ceramic abutments and ceramic restorations, which is coming out of the gingiva, will definitely give you a more natural aesthetic look. Is not about only the white aesthetic, is about the pink aesthetic I'm talking about, where when this all ceramic restorations are coming out, they are not changing much of this gingival view about the gingival margin of these abutments, and that's much of micro aesthetic elements are being matter to most of the patients which are aesthetically more concerned, and being an implantologist, being a more accurate and being a more I would say perfect implantologist, you should always respect all such small things which actually matters a lot for these patients. Before going to this, I would like to get some questions. Anybody has any question? Okay. Probably we'll take it at the end. Fantastic. So let's go a bit ahead now. Let's talk about a bit of a mucosal thickness now. So we have talked about the type of abutment which are coming out of the gingiva is of course anything coming out of the gingiva white in color will be definitely more aesthetic. What if your but the abutment contour has a very important criteria to follow or to provide the success or overall aesthetic outcome for these types of abutments. Now look at this particular schematic where your tooth has been engaged with this much of a socket graft. Your implant has been placed a little bit on the palatal side, and some of the bone graft has been done here. And then your abutment has to be pop out of this gingiva, of course. And then, so this concavity will provide a bit more room for increasing the mucosal thickness. And if your abutment can shape up like this, probably will be having a more aesthetic value in terms of your overall aesthetic outcome for these types of abutments. So it's not just about the material now, it's also about the contour of the abutment. What is the shape of the abutment is coming out of the bone and out of the gingiva, and that's exactly is the areas which has been described nicely in this article, 2020 article, and they have classified these different contour areas into subcritical and critical contours, and then the regeneration space for these types of abutments. Well, so when look at the tissues, so the area which needs to be concave a bit more, which will allow a bit of more mucosal thickness, will definitely give some additional point or additional aesthetic value into adding up some micro aesthetic elements in these types of restorations. Now, if you are really going for the tooth colored abutment, which is popping out, will be having not much of an issue, but if it is coming out with the help of a metallic abutment, probably it will matter a bit more. So if you're coming out of that, it will giving you a bit more customized. So that's where the customized abutments are playing into a role. where you can see that Dr. Harsh will talk a bit more about that. Definitely, yes. So these are the criteria, these are the areas or patient selection points which needs to be taken into consideration while selecting these types of abutment, whether you should go for customized abutments or just a prefabricated circular cross-section abutments, or matching or changing the material of these abutments. Okay, so when you look back to the classification or a flow chart, if you want to select the abutment which is based on the gingival thickness, and typically if it is less than 2 mm, you can say it because 2 mm has been shown in some of the in vitro studies, also previously shown that anything less than 2 to 3 mm of gingiva are a bit more aesthetically tricky ones. And if that is there, if a thin bit gingival phenotype, probably you should go for ceramic abutments, or sometimes you should be go for customized abutments. Ceramic customized also, of course, yes. If your gingival thickness is 2 or more than that, that's a thick biotype, thick phenotype. But your gingival scalloping is a bit more exaggerated, then probably the custom titanium abutment is the choice of abutment. And if there is a bit of not like usually for the posterior zone, there is not much of a scalloping, and then not a very exaggerated scalloping, it can be a flat scalloped gingiva, you can straight away go for titanium or prefabricated, not customized, but just a titanium circular cross section abutments, and that's fine. So this is what is the one of the criteria you can take home today while selecting your abutments for your cases. Based on the material aspects, titanium, zirconium dioxide, and gold abutments are available. Recently, there are polymethyl methacrylate and polyether ether ketone materials are also available, but they are only used for provisional abutments. But for the final abutments, standard abutments, you can use titanium standard abutment, which is very straightforward, and zirconia abutment, which is also another straightforward abutment. If you want to do a customized abutments, you have a titanium as a material of choice. Sometimes you have a gold customized abutments available as well. If you want to go for customized CAD/CAM abutments, you can do the milling, even take out with the titanium as well as take out from the zirconia abutments. So you have a customized CAD/CAM abutment nature, which can be milled out from titanium as well as from zirconia. Of course, and titanium also can be used for provisional restoration. So based on what type of abutment procedure. So this is a classification table taken up from one of the ITI online academy lecture by Julia. And so you have a provisional abutment options in titanium, in PMMA, and PEEK, the last column I'm talking about. You have a customized CAD/CAM abutment option in titanium and zirconia, second last column here. You have also customized abutments. You can do that with the titanium and gold as well. And then there is, of course, a standard prefabricated abutments available. Like those are the prefabricated, all these are prefabricated abutments. And these can be also in a titanium as well as in zirconia. Well, so now I'm coming towards a bit of more refined version of understanding about these implant abutments. Of course, you have understood there is a what is the yes, engaging abutment and then the non-engaging abutment. So typically, those who are having some degree of hex nature of or some notches or some straight surfaces and little bit of longer, they are engaging abutments, typically given for single tooth or parallel implants. Non-engaging abutments are, so this is about how much of amount of area or how much of the shape of the abutment is engaging into the implant collar. Okay, the abutment space, you can see now there's a round top here. You can see there is a stepped notch here now. So there is a reason why these types of abutments have a step here. And that's okay. So first thing first. Now these all types of abutments are also called as a titanium base abutments. Now these are basically a titanium base, but all these abutments will allow the sticking of the CAD/CAM crowns, which can be glued with the special type of a glue, which you probably your technician might be doing this in the lab. You can do that in your clinic as well. But the selection of the abutment, you can see this abutment is actually the exact shape of this abutment. So part of this area will go onto the implant. So these notches will be copied down into the crown CAD/CAM milling or any type of restoration further you have fabricated. So this crown will be stick onto the titanium basis. That's where one of the widely used abutments are coming into the market, coming into the clinical practice nowadays, and those are basically milled abutments or zirconia abutments or even metal ceramic abutments, but they are stuck onto the titanium bases, which are machined bases, and they are engaging the implant body as such. So this separately milled or separately fabricated crown can be glued onto this titanium basis, and then you will be screwing the whole one piece of the screw retain prosthesis onto the implant when the screw retain crown will be sent back to you in the clinic. Well, so notch. So why this step here? So when you want to understand why there is a step into this abutment, you can see now that your implant angulation is straight up. If any implant has been placed a bit in angulated manner, and if you want your crown to be slightly changed with a little bit on lingual side, your screw axis hole, for of course I am talking about the screw retain prosthesis now. So of course we have a straight screw driver which has to go straight. So the hole should be here. So that's where the straight screw axis channel works on. So something called as a dynamic abutments, or there are some notch abutments which are there in a practice nowadays, which will allow your screwdriver to go from little bit of different angulation. And to me, this is one of the paradigm shift of implantology. If you have a abutment that can be screwed down with a different angle, but screw go into different angle, that's where most of these abutments have changed the screw axis channel somewhere on the occlusal surface or somewhere on the lingual side. But from this angle, your screwdriver will come into and then engage the screwdriver or your abutment screw, and then the screw will go in this direction. You don't have to go straight screwdriver axis. So that's where it is called as a angle screw channel. Now, you don't have to worry about whether what direction your implant. Of course, sometimes if you are maxillary aesthetic zone, anterior maxillary, the implants are always been tilted on the labial side. And then if you want to use the screw retain prosthesis, there is always a risk that your screwdriver hole is coming on the labial surface. But now you don't have to bother about that because you have a screwdriver which can go in a different angle, and then your screw will go and engage in a different angle. So when you tighten it from the lingual side, so that's where it is the angle screw channel concept comes from. It's just in physics. Now how it works. Now you can see now there are some types of a different nature of these screwdrivers. When you look at the screwdriver heads, they can engage with the angle and then the screw will come down. So you have an axis, you have an angled screwing and unscrewing nature. That's why there is a notch here. Even the dynamic abutment has its own thing. I'll show you the video how the dynamic abutment also works. But this is what is called as an angle screw channel. This is what is also called as angle screw channel, and almost all companies are rapidly shifted in this. And most of these dynamic abutments and an angle screw channel abutments are much more popular now, and almost every implant manufacturer has this option now available. Well, so how it works? Let me just quickly go through it. It's a YouTube video. You can just Google it, dynamic abutment solutions. So let's say this is an implant and this is a plastic body which can roam around. So that's why it is called as a dynamic abutment. So you can change the direction of the abutment on the other side. Now this one at this condition 20 or 20 degrees. So screw will come from this and then go down that like this. So you can see the screwdriver is in an angle. So the same plastic coping will be waxed up. So in clinical scenario, when you look at it, let's say maxillary anterior region, your implant has been placed on almost on the labial side. So when you want to have a straight angle, your straight screwdriver channel will come on the labial side, which is not aesthetic. Of course, so you want to change the direction the way your screwdriver comes from the lingual side. So that's where the dynamic abutment comes into a picture. So your implant direction is here, your dynamic abutment seats onto the implant, and you can change the angulation of this plastic coping on the lingual side. Yeah, so dynamic abutment usually will be having a little bit of bigger abutment access hole. Yeah, labially you can wax up a bit. So this is at the lab stage, is on the cast. So you have to wax up a bit of that around the dynamic abutment, which is plastic white color abutment here, which eventually will go for casting. So once you cast this wax along with the plastic coping, it will come out like a metallic casting, and the screwdriver will go like this, and then with a different angle, you can screw it. And then you can do the ceramic veneering on top of these abutments, leaving the space on the lingual side. So that's how it works. That's how the dynamic abutment works. And to me, yeah, so you don't have to go for cement return prosthesis in this case. You still can use the screw return prosthesis with the angle screw channel restoration. Okay, so that's what is. Okay, I'll go back and then shift it to the. Yeah. Okay, so this is the clinical case where the implant has been placed, and then you can see now the angle screw channel screw. So the implant is in different direction, and then the screwdriver is going from the lingual side. So this is a typically a dynamic abutment has been placed and screwed in with a good aesthetic outcomes. This, of course, the natural tooth needs to be a more aesthetic veneering and crowning later on, but this is the lateral incisor is the one which is the implant restoration which has been in place. Well, so talking about the customized abutment, I will not talk much. Harsh sir will touch upon quite a lot, but this is what is basically has a pre-milled blocks available with the machined engage area or the platform, and then the whole block can be milled out in the titanium milling machine, or even a zirconia can be milled out from a zirconia milling. So these are all customized abutments, and they have their own advantage because they are quite a good aesthetics. Imagine your premolar restoring with the perfectly circular cross section and something like a anatomical cross section. Definitely the one which is having an anatomical abutment shape will give you better results, will be more easy to maintain long-term periodontal peri-implant success, as well as the aesthetics, definitely. So this is a classic example, one of the gold anodized customized titanium milled abutment, which is there in place. And you can see now shape up, you can modify all this milling in the software the way you want the shape of the abutment come out of the implant. Of course, the base part will always remain machined one. You don't have to cast it, or you don't have to mill it anyway. So the machine portion will remain the constant onto the specific implant system. Whatever changes happening on the top of this milling surface. So these blocks will mill out the abutments for your, and then there are different manufacturers come to into a practice about these restorations. So when you only don't have an option of a dynamic abutment, but to change the angle of the abutment, there are two more options available. One is a multi-unit abutment, where your implant is in a different direction, but then there is an intermediate abutment, which is the intermediate abutment will help you to give some additional bulk of metal for the actual final abutment to change the direction. So these multi-unit abutments that's why they are called as a multi-unit abutment, because there is another abutment piece which is coming in between the implant and the actual abutment. So that's why there are two abutment portions or two abutment sections, two abutment units, I would say. Of course, the black things are all abutment screws. So the first abutment screw will go engage on the implant with a straight axis, and then part of the metal which is remaining here will allow the metal to screw in the main abutment screw axis. So that's where the multi-unit abutments, and it's been famously known and used for all-on-4 cases, and typically started with one of the pioneer implant company, but most of the premier implant systems have these types of abutment systems now. They are called multi-unit abutment because there is an intermediate abutment which will allow the segment to go in with a straight axis first, and then there is a different axis for your abutment, the actual main abutment. So there is a 2-unit abutments. That's why it is a multi-unit abutment. So when you, in a nutshell, when you look at the schematics, there are cement retain prosthesis, there is screw retain prosthesis, and then there is a screw cement retain prosthesis. So screw end table or screw or cement screw retain prosthesis. Now, screw retain prosthesis, what we talked about is a straightway screw retain or angled screw axis channel. And one more option is a horizontal screw axis channel. Now, horizontal screw axis channel is something which has an engagement of abutment, but you can tighten the screw from the lateral side, which is much more still into a practice. There is some mechanics which engage the abutment from the lateral side, and the abutment will be stay there. So that's how the mechanics of the fixing up the abutment, that is also called as a lateral screw abutment. So for screw retain prosthesis, if you want to change the abutment screw axis channel, there are 3 options. Number 1 is multi-unit abutment, which will be having additional abutment unit. Another is dynamic abutment, which is having a lateral screw axis channel. And then third is a lateral screw abutment. So these 3 options are available for screw retain prosthesis. Of course, the another category is angled cement retain prosthesis, where individual abutment will go onto the implant. Individually, you can tighten up, you can angle it, or you can be straighten up, and then the whole cement retain prosthesis will go on. That's typically a conventional manner. But when you look at the screw retain prosthesis, where you need to have an angled screw axis channel, these are the 3 options. I hope it is understood well. Okay, so this is the screw end table. The one which I just mentioned is a titanium base abutment with the whatever CAD/CAM, zirconia or metal ceramic restoration can be glued onto the screw. So has taken advantage of screw as well as cement. That's why this screw end table or cement screw retained prosthesis, and one of the widely used abutments nowadays. One of the popular options. We also have classified based on this, because this particular table has been coming from one of our article, JPD article, with one of my 2 great colleagues from Mumbai, Dr. Udatta Kher and Ali Tankiwala. They have almost 5 different cases we use with the different types of abutments, and it's a great article to go through. Just check, and then we have categorized different types of abutment categories. One is with a cement retain angle prosthesis. The other one is the straight abutment. There is another is a angled the multi-unit abutment. One other is a dynamic abutment, and then also we have one case with the lateral screw axis channel also. And what are the different indications and advantages, and what are the limitations of each of type of these abutments, if you want to have a look at it. Okay, once you cascade down to the abutments, you need some height for screwing up these types of restorations, and minimum 7 to 8 millimeter of height is required. to screw these types of restorations. Of course, for the cement retained also. So for cement retained prosthesis, you need a little bit of more height. If you land up with a less than 6 to 7, about 6 to 7 millimeter or a limited height, you probably are selecting the screw retained prosthesis, because cement retained prosthesis may dislodge due to the less height of the abutment. So screw retained prosthesis also will be requiring minimum 7 to 8 millimeter of height. And if you don't have that much, probably you need to put the implant a little bit down with the trimming out of the bone, or sometimes trimming out your opposite occlusal enameloplasty and so on. So make a room for implant prosthesis minimum 7 to 8 millimeter. That's minimum requirement which you can think of. Okay, so about fixed restorations, almost done. We have another 30 more minutes. And now we are going towards the removable abutment systems now. So on the right, third and fourth picture, which we talked about a lot about this, is these are typically a cement retained abutments, or sometimes a screw retained abutments. All are fixed, and you can do that. The first and second picture is about the removable abutments. So these are basically typically called as a implant over dentures. It can be a implant over dentures with a unsplinted attachments and splinted attachments. We'll talk a bit more about this later on. But before that, I want to let you go through this amazing classification. The one is, of course, this is from the Mish, and he has given this fixed prosthesis classification 1, fixed prosthesis 2, and fixed prosthesis 3. Based on the bone volume availability and the maintenance of bone height, straightforward cases are FP1, where there is no bone loss, there is no soft tissue loss. A little bit of moderate bone loss, soft tissue loss, there is called as a FP2, which you land up with a little bit of longer prosthesis than usual. The third category, even you have a little bit of severe bone loss, where longer prosthesis may not work well, but you also have to add some pink porcelain to give up fixed restorations. If you expect more than this bone loss, probably fixed restorations are not that greatly advocated. And that's why they changed the FP1, FP2, FP3 to RP4 and RP5. That's the basic difference between FP1, FP2, FP3, because they are fixed restoration. If you give a bit more bone loss, that becomes your removable prosthesis. So if you have a more bone loss, of course, we are talking about the completely edentulous arch, or it is also indicated for partially dented solution also. But if you have a more bone loss than usual, where even if your pink porcelain is not going to work well, of course, you can still go for fixed restorations, but those prostheses will be more bulkier, having a more weight, and will be having a more trauma to the underlying bone. So that's why if you have a more bone loss, probably fixed restorations are not option, but you need to go for removable prosthesis. So RP4 means more number of implants and joined together, more or less. Stresses point of view, they are very close to the fixed restoration, but still the restoration can be removed by the patient. RP5 is less number of implants. Part of support is gained by the mucosa. So this is where the typically implant over dentures come. So this is first category is RP5. The second photograph is RP4. Because you have a more number of implants, you have splinted together, and then the whole of support is gained, or the whole of the prosthesis support is transferred to the implants. So basically they are very close to the fixed restoration. They still are removable, but they are fixed restoration. That becomes your RP4, and this becomes your RP5. RP5 where less number of implants, and the part of the support will be gained by the mucosa. So that's where there is a one great classification. Unfortunately, this publication has been published in not so high impact journal, but numerical guidelines are wonderful. You can just see that if you have a 10 to 12 millimeter of intra-arch distance, fixed options are available. If you are losing more and more bone, that means you are having more and more inter-arch space. And if your intra-arch space is more than 18 millimeter, probably fixed option is not indicated, but you should go for removable option, and that's where the implant over dentures treatment options comes into a picture. So implant overdenture options, when you talked about it, if you have a more space, you can have a bar retained prosthesis. If you have a lesser space, you can have a ball and socket type of restoration or a socket type of attachment. So typically, if this is a stud attachment, they are called as a unsplinted. If you have a bar abutment, it is a splinted abutment or splinted attachment. So a little bit of definition about the overdentures. It is a removable prosthesis that is supported by dental implants and related tissue structures. So either can be attached with a clipped with different unsplinted attachments, or it can be also attached with a bar and clip attachment, which is splinted attachments. So they have a matrix part of the attachment, which will go usually fixed into the implant underneath, and then the matrix part, the male part will go and fix with the implant, and the female part will go into the denture as a flexible component or receptacle component. And that's where the friction between this flexible component and the round metallic portion will give you a bit of clip kind of attachment or retention. That's how the implant overdentures work. So there are typically unsplinted attachments are also known as stud attachments or ball and socket attachments. There are different types of designs available. One of the most famous type of attachments are locators. Number 3 here, where the top is flat, not like a round like this ball and socket attachment, but more or less all these stud attachments has a common nature of attachment, fitting nature, that is friction by flexible receptacle or flexible nylon caps. So there is also kind of a O-ring attachment, which will be like a car tire type of design, where the O-ring will go and fit into the neck of the implant here. So this is the O-ring attachment. So all these are stud attachments. There is a Dalabona attachment, one where there is a metallic prongs which are bound by the rubber band outside. So metal to metal contact, less wear resistance, not very famous in practice. One of the famous options is still the locators. These are also very famous, ball and socket with a nylon cap. The locator attachment has a dual retention category, where the internal embossing also will add some retentive value to the locators. And locators are being a flat on top, they can accommodate a lesser height. That's what the manufacturer claims. If you have a less intra space, provided locator attachments are the choice of, and they are universal attachments. So you go anywhere in the part of the world, locators are like a universal attachments. You can fix it any part of the world if you have a locator attachment in place by the patients. By advantage, as these types of attachments are very convenient for use, and they less required less chair side time and so on. Another category called as a magnet attachment, which are usually typically reserved for very, very old patients, because these magnetic attachments will give a little bit of less retention, but it is very easy to maintain by those very old patients, which cannot, because these attachments, the stud attachments are quite heavy in retention. Yeah. Those patients who are debilitated, having a less muscular control, neuromuscular control, all these patients, the magnet attachments works best for them. And of course, the third category is a bar attachment, which can be also called as a splinted attachment. The advantage of bar attachment that the stresses are transferred uniformly onto the all implants. The unsplinted, in a stud attachment, it is not the case. But the down part of the bar attachment, that it requires more space. So so that's why if you have a more bone resorption, that means more intra space, it is also accommodative for bar, go for bar attachments. Yeah, that's how. But study says that no matter whether you are putting the bar or ball attachments, for stress purpose or stresses purpose, clinically point of view, more or less all types of these attachments are working favorably well, and not much of a significant difference though. Yeah, so you need to understand how the implant supported and then the implant tissue supported prosthesis works. Implant supported means your bar is completely covering the whole of the edentulous arch. All the occlusal stresses, masticative forces are directly transferring onto the implant. That becomes like a typically only implant supported overdenture. And that's possible. So RP4 category, all are like that. You don't have to do only 2 or 3, but it can be placed 2 or 3 implants or even 4 implants. The implant tissue supported restoration, or sometimes called as a implant retained, not completely supported by the implant, where part of the masticatory forces are transferred to the gingiva or posterior edentulous arch. And then the anterior studs will only provide the kind of a retention. Of course, part of support will also be transferred onto the implants. That's one way. But these types of overdentures are called as the implant tissue supported overdentures. But there is a problem. If when patient bites on backside, the fulcrum will keep on dislodging these types of restoration a bit, and that's how it works. Well, so looking into some types of different category now, we have talked a lot about the two-piece implants now. The mini implant is something a category which is thinner in diameter. That's why they can make it a single piece implant. So there is no connection. There are no abutment screws here. Okay, but they can be used like a ball and socket or locator attachments also available. Anything less than 3 millimeter usually considered as a mini dental implant. They are less invasive because they require less amount of bone. And of course, they are less expensive because there is no complex mechanics involved. That's why. Of course, but when you are using the mini implants, probably, yeah, this is the difference between the conventional implant size and the mini implant size. But if you are wanting to use mini implants for overdentures, probably most of the manufacturers recommend to go for 4 mini implants. There are some advanced mini implant systems are also in place, and they can also be used in some of the lateral incisor missing or lower incisor missings, and you can achieve a better aesthetics with this. But limit it only for anteriors. There are many other implant systems. I think that's like a cortical implants or something, basal implant systems. Not going to work that way. I not really recommend the basal implants which are having a single piece and putting like a screws everywhere on the arch, and it's very difficult to bend, and then very difficult to maintain the parallelism, and then you cement the process is crazy. Yeah, so basal implant is the one which is still in a questionable treatment option. I do understand there are many clinicians who are recommending the basal implants. Probably I am yet to place one about those types of implants anyway. So there are another few more options available in the market, which are also called as a fixed removable attachment systems, which are fixed for teeth, fixed for patient, but it can still be removable for dentist. So these attachments are having an advantage that if anything goes wrong with one of the implant, you still can use the same processes, unlike your fixed restorations, and you can place another implant and then pick up the another attachment into the same restoration. There is another category which recently been introduced by Zest Dental Solution. Now the Zest Dental Solution is the one which supplying the locator attachments worldwide. So this is a universal attachment. You go any part of the world, you will be having the same design of the locator attachment. Removable attachment is very famous. What they come up with is a fixed restoration or attachment where they have increased the retentive ability of the nylon cap too much stiff, so that for the patient is almost as good as it is a fixed restoration. But based on for the implant, for the clinician, it is still a removable prosthesis, because you can, with the help of special tools, you can still take out this restoration. So this is the locator fix, which has been recently been introduced by Zest Dental. So it's the same attachment like your removable one. Only difference is the nylon cap is more stiff, and the denture flanges needs to be rounded up like a fixed restoration. So that is one of the best advantage you can have, which is called as a locator fixed restorations. Yeah, so last 15 more minutes, we can talk a bit more about the complications due to the different types of abutments and non-original abutments. Now, hardware complications are usually are combined ones, or combination of mechanical and technical. Mechanical means anything related to the manufacturing problem. Technical, usually anything related to the laboratory technical problems or technology or technician problem. Usually it happens together. One of my case, good bone volume, almost 5.5 or 6 millimeter diameter implant. We have placed the aesthetic implant, and then we placed the crown, and then patient was using. After 6 to 9 months, patient called me back and said that, doctor, my tooth is loose. And I see no reason that this implant abutment should be loose. And when we look back why it happened, analyze quite a lot, talking, checking with the lab what type of stuff you have used, and what we found out that the abutment which was used in this case was casted. So when you see the casted means they have a wax pattern of these abutments and they do the casting, and then the casted portion of the abutment is actually engaging the implant. To my view, there is no way you can achieve the precision fit of this non-original casted abutments with the implant, inner part of the body of the implant or collar of the implant. And that's where micro motions start happening, and then the crown will start loosening up. And this is a serious issue now, because it is much into a practice. Many laboratory technicians are using these casted abutments only because they can save money, because this casted portion or casted abutments are quite cheap as compared to your original machined abutments, and that's where the problem is coming from. And as a clinician, you must know whether this abutment is machined or whether it has been casted one. Of course, there are many other issues like implant placement. This is definitely not an ideal implant placement with too much of cantilever. It's definitely going to give excessive stresses on the mesial side sometimes, and abutment, even sometimes implant fracture has been observed in some of our cases, not only because of the implant cantilever crown length, but also because of the abutment non-original casted abutments. You can see now there are some spaces where it is not achieved a precision fit into the implants. Some of the casted abutments do not have much of engagement inside. And look at the data here. Look at the edge of the abutment just resting on it, and there is no way that this abutment is going to last longer, and it has to be loose, and then it is actually loose, and then what we observed is actually implant collar fracture. And unfortunately, this bridge also has to be out. And so a lot of research has been happening around this area. One of the JPD article where they have evaluated the original versus non-original casted abutments and checked with the internal fitting and long-term fitting performance. And when they evaluated all these items, you can see the gap between the original abutments are less in microns than the non-original abutments. When you look at the fatigue limit, or when you look at the tight contactness, if you have a tight contact, original abutment will be having tight contactness in more percentage than the non-original abutments. You when look at the amount of fatigue limit, original abutment will always show up a higher fatigue limit than the non-original abutments. So this is come from one of the in vitro study, and what they concluded that the occlusal loads are transferred more homogeneously through the system when original abutments are used, because of the better fit between the internal components, leading to increased fatigue resistance. Yeah. Original and non-original, sometimes non-original abutments are not even engaged nicely into the inner implant body, and that's where the amount of engagement of these abutments also is a very critical element in terms of long-term success. We do have come across a lot of implant body fractures due to these non-original abutments, which later on we come to know that our laboratory was using this without clinicians' knowledge. And you can see the thin edges, and there is no way that these implants needs to be taken out. And unfortunately, yeah, look at another case with the use of non-original abutments. You can have an implant body fracture, which is very quite evident. no choice but to remove the implants. We shifted by explaining to the patient to just one placing implant with the one original crown here because of the less interocclusal space in the 7th region. So look at the 2, 6, and 7, 4, 6, and 4, 7 implant restoration. Of course, cantilever was one of the reason, but the major reason was usage of non-original abutment. And later on, we have just placed single molar crown with the original abutment in place. So these are the ones. You go onto the ebay.com or Amazon, Google it, and search for the implant abutments. You do get a lot of ranges of these types of abutment options, and they are available for any available implant system in the world. Yeah, so they can make it all duplicate items. The riskiest part is the casted patterns. If you have a casted abutment which is going to rest onto the implant, these are still fine. The machine abutments are still, of course, the original, non-original machine by different company is not going to match the one with the same implant manufacturer has done it. That's one way. But the worst thing is the technician is also doing some casting of these abutments and then trying to fit those abutments onto the implants. These implant abutments, almost all are coming with the loose implant abutment crown. And beware of these types of abutment restorations if your technician is being fabricating such restorations. There is almost 40 studies comparing original versus non-original abutments, and what they found out that you should use only original abutments, because non-original abutments are giving a lot of catastrophic problems in a way. Because of that, implant body fractures are happening due to the abutment screw loosening, or abutment screw loosening is coming first and then implant body fracture is coming later. That's also an chicken and egg situation. Okay, for cement retain restorations, when the crown get loose, you have to take access from the label side or whatever screw access channel direction, and then that's where you land up with searching where exactly is my screw access channel so that I can remove the screw, the cement retain abutment along with the screw, because sometimes it's very difficult to de-cement the crown by just doing some back action force. Even if you use the weak cement like zinc oxide ethanol, that's what they recommend for implant restoration so that you can easily remove. But even if the zinc oxide ethanol cement is sometimes it's impossible, look at the long implant abutment. Even if it is cemented with the zinc oxide, I don't see there is any possibility that this crown is getting de-cemented, and you can't apply more force, otherwise that it will damage the implants, the original implants in the bone. So that's why taking a screw access channel is always a better choice. If you don't have that much of access, you can just take an X-ray and find out the long axis of the teeth and then correlate those position to take the axis for the implants. Also, there is a possibility that you can just save one more photograph of this cement retain prosthesis and then save it as your patient record, so that you know in terms of in case in future some prosthesis is loose, you know where to take the axis from. So this is like typically saving the photograph, cement retain restoration. Of course, because of screw retain prosthesis, there is always a screw axis channel available. But if you are cementing the prosthesis, always take one photograph checking where exactly the screw axis channel is coming from, and save that occlusal photograph as a patient's permanent record. You can WhatsApp, or you can just send that patient to the patient to the patient as well, and maintain that patient record so that you can take access. You know where in future to trim to get the access for the cement retain restorations as well. Using the final abutment screws is another key to success. Sometimes there is different implant systems will use lap screw separately and final screw separately. Some final screw abutments are always have a good practice so that your abutment screw loosening chances are lessened. Some manufacturers will also give some guidelines about how tight is your implant abutment screw, based on your tightness, based on their own calculations, based on the screw pitch, based on the material, based on the fatigue nature of their abutments and based on the whatever type of metals and alloys they have combined and used it. So these values are valuable. They are provided by manufacturers. Not all abutments needs to tighten up to 35 Newton centimeter or 20 Newton centimeters. So look into the manufacturer's instructions for that. So if all these types of restorations, abutment screw loosening is a problem, one of the commonest problem is abutment screw loosening. And if you want to avoid whether the single piece implants are still available as a choice of a implant, that's still a question. And of course, the single piece implants usually are still reserved, I would say, for the overdenture attachments as well as some anterior crowns like upper anteriors, upper laterals especially missing or lower anterior missing only. ITI guide, 5th ITI consensus has given some preventive measures for preventing these hardware complications. And when you choose the implant, choose with the best manufacturers. When you choose the prosthetic screw, avoid mishandling or misfitting of these prosthetic screws. When you choose the abutments, use with a greater caution with the ceramic abutments, because ceramic abutment has a greater tendency to chip off very easily. And framework and veneering material also needs to be carefully selected based on that. So for overall success, there is a contact we need to take care, there is a contour you need to take care, and there is a connection you need to take care. So there are 3 C's for successful implant prosthesis you need to keep in mind. So few take-home messages. Your abutment selection is in general a straightforward process. When you know different types, they are not very, it's not a rocket science. You know, if you want to have a different screw access channel, just select the different screw access channel abutment. If you want a cement retain, you just use the cement retain processes. Yeah, you need to have that set the goal in mind, whether you need a passive fitting of the processes, cement retains are best. If you still need a retrievability in terms of future retrievability, screw retain processes is best. So not very rocket science, but if you know all the options available in the market, then you can choose the best abutment for your case, for the best outcome. Prosthodontically driven planning will facilitate the selection of abutments well from wide range of materials, designs, and fabrication processes. Titanium abutments works best for almost all situations. You don't have to go for the zirconia abutment all the time. Customized and zirconia abutments works great in aesthetically challenging and demanding patients. Yeah, and always use the original abutments. Thank you very much. And the floor is open for questions now. I have 2 more minutes left.
Thank you, sir.
Hello.
Thank you.
I would request our Dean, Dr. R.V. Subramaniam, to kindly present Dr. Patil with the e-certificate.
I shall virtually hand over the certificate to Dr. Praveen Kumar Patil.
Thank you,
you
sir.
so much, sir.
Appreciate it. Thank you very much.
Thank you, Dr. Patil. You've been very generous with your knowledge sharing.
You have shown
It
the
is-
certificate of Dr. Harshvardhan.
डॉक्टर हर्षवर्धन के लिए आपको वापस आना पड़ेगा सर.
उसका सर्टिफिकेट पहले मिल गया है, तो उसका लेक्चर हो गया है.
No, we have this one.
I think the slide number 8.
Yeah.
Yes. So thank you so much, sir.
Thank you.
very
Thank you,
much
sir. Thank you very much.
for such a wonderful and exhaustive lecture on abutments in implant prosthodontics. Thank you so much, sir.
Yeah. Thank you, sir. Thank you very much.
Thank you, sir. May we now move on to our second speaker of the day. I'll introduce Dr. Harshvardhan Arya. Sir runs a private practices with an emphasis on dental implants, CAD/CAM based restorative dentistry. He is also co-guide on research projects on FEM and rapid prototyping in the Regional Engineering College at VNIT Nagpur, and has several international publications. He runs a dental laboratory also with focus on all ceramic CAD/CAM restorations and implant superstructures. He has lectured extensively all over the country on restorative dentistry and implantology at various workshops and conferences, including MIDEC 2018 at Kuala Lumpur, Malaysia. He is the second person in India to be certified by Digital Dental Academy, Berlin. And currently, Dr. Harsh is the key opinion leader for chairside dental CAD/CAM technology, CEREC, for the Indian subcontinent. I request Dr. Arya to please take over.
Thank you very much, ma'am, for that kind introduction. It's my pleasure indeed to have two of my very best friends, Dr. Praveen Patil and of course, Dr. Rajesh Seturaman, who was kind enough to invite me for this wonderful symposium, if I may say so. And I'm very glad that Department of Prosthodontics has chosen such an important topic, because nowadays we see a lot of conferences and seminars on implantology, on grafting, on surgical aspects. But very rarely we focus on things which matter on a day-to-day basis for those who practice implantology, and implant abutments certainly is one of them. So after Praveen's wonderful presentation, let me try and share. Okay. All right. Are you able to see my screen?
Yes, sir.
Yeah. All right. Great. Okay. Fine. So I really admire the patience of the audience to go through two longish lectures. Of course, Praveen made it very interesting, and in a matter of 1.5 hours, he has managed to cover more aspects of the implant abutment, the criteria for their selection, and the pros and cons of various mechanisms and systems which are available today. So my job has become far more easier, and I will try to make it as simplistic, as useful for you as possible. So my topic is customizing implant abutments, and basically we are going to see how and why do we customize abutments in implantology. So for me, implantology today, or implant, is like this tree. And as you can see in the picture, you have the tree above and you have the root below the soil. And if I try to draw an analogy here, the roots represents the implant, and the actual tree represents the restoration. So what really matters to us is the restoration, and more than us, what really matters to the patient, as Praveen rightly said, that they come to us for replacement of their teeth, aesthetic and functional replacement of their missing teeth. They don't really care what type of implant, what type of abutment, and what complex system or technology we use. Hence, our focus as any conscientious implantologist should be on the quality of the restoration. So I always say this, that what lies beneath the bone is less important than what lies in the mouth, right? So because the technology and the quality of all the implant systems available today has reached to a pinnacle, that most systems you will find that they possess all the necessary features that are needed to guarantee a successful osseointegration, give and take. So they have, as I sometimes jokingly say, that a screw is a screw. How many times would you change the design? You change the pitch of the screw, you change the surface treatment. Now everything has been tried and optimized. So if you pick up any decent system available in the market, they will have very similar features. So right from surface treatment to connections to the grade of titanium to the components, right? So the era where we focused on the implant as such and the surgical techniques is gone. I wouldn't say that it's not important, but it is something which is given, which is already practiced by all implantologists pretty efficiently. But today the era is to optimize the restoration which we provide onto the implant. And our effort should always be to ensure that the implant crown or the implant prosthesis as much as possible resembles the natural teeth and tissues. So this is the stock abutment portfolio. So it is like something which every implantologist has seen on the catalog of their implant system which they use. And sometimes it is so voluminous that it is a big book. The catalog is a big, huge book. And you have to go turn pages after pages, seeing all the possible combinations of implant, abutments, their collar heights, their angulations, the mechanism by which they can be processed, etc. and etc. So stock abutments have been a big part of implantology right from the early days, because as I routinely say, that like in a marriage, in a wedding, the abutments come as barati together. So if you buy 100 implants, usually you strike a deal with the implant company. You buy 100 implants and 100 abutments come free, whether you like it or not. Right? So the dentists over the last few decades have tried to use, of course, because they already have implant abutments lying with them of various sizes, and they will try and use that, thrust it upon the laboratories and ensure that they try to utilize and finish all those abutments which are stock abutments which are lying with them. Now, to be very honest, this era of stocking abutments in your practice or in your department has to go away. Now we are looking at a time where you should be only buying implants and then choosing your abutments according to the need of the case. So I think Praveen has beautifully showed us various scenarios today where we can employ different types of abutment, different retention mechanisms, and different ways of processing them in order to optimize. So this is the era of customization. This is not the era of using what is already lying in your cupboard. So when we talk about stock versus custom, so there were times when we were young, most of our clothes were stitched because there were very little of ready-made stuff available then. But today we have come to the era whereby everybody buys their clothes online. You don't even go and try them. It is delivered to you on your doorstep. You try. If you don't like it, you send it back. So, we have been used to custom, which is everybody in India knows this particular vehicle. But today the era is of optimization, and where we can achieve much more desirable results, if you like, in our quest to get optimal results out of our implant protocol. Now, Praveen talked about cementable retention mechanisms, and all of those of you who have practiced implantology for some time, say, for the past 10, 15, 20, 25 years, will also agree that cemented restoration was the norm when we started doing implants maybe 20 years back. And to be very honest, we have little problem with it in the long run. Although the literature will always tell you that the problem of excess cement going into the implant sulcus and implant mucosa, which is causing peri-implantitis. Yes, of course, that is a real concern, and that is one very strong reason why we want to avoid it. But if you do it right, the cemented prosthesis still has a lot to offer, and you can achieve very long-term results with minimum complication. So for example, if I show you this case, which I did almost 20 years back. So this gentleman came with mobile teeth, and obviously they were tied up with wire, which is a clear sign that they all have to go, and all of them were extracted. So many implantologists feel and when they say that this is the permanent treatment of periodontitis, that is extraction of all the teeth. And then, of course, purely cemented prostheses made on stock abutments were prepared and delivered immediately. So this was a case of immediate loading in the mandibular arch. And it has survived till date without zero complications. This patient was from abroad, and all the reasons why we want to get things right. And when you work, even with a cemented prosthesis, if you do your things right, that was the era where PFM restorations were made routinely for implant rehabilitation, and these type of crowns and bridges were casted and layered as they were done for natural teeth, right? So this is a radiograph of a case, again, a different case done almost 20 years back. And you can see that everything is stable. This is a recent X-ray of a young girl who was about to get married when we did, all these implants. And those were the days where there were no screw retained restoration. There were no multi-unit abutments. And of course, there was nothing digital available then. And pure analog impressions were made. Stock abutments were used and modified in the laboratory, and cement retained prosthesis were prepared. So we didn't even know about giving an access hole in the occlusal surface wherever possible those days. But having said that, except on the lower left quadrant where you can see a little bit of excess cement which is still stuck, past so many years it has survived without any problem. So cemented prosthesis is not completely out, and as Praveen rightly said, that it should still be in your portfolio for solving some cases. For example, an anterior restoration with screw access hole coming right on the labial surface of the crown. Very few things, you can use angulated screw channels, you can use dynamic abutments, but sometimes it is so much far easy to just use an angulated abutment and make a simple cementable crown. Of course, we try and use cements which will be easy to retrieve. But having said that, and we take a lot of care, of course, not to allow the excess cement. Many techniques, like we use a pseudo abutment outside the mouth. First, let the excess cement out, and then use minimal amount of cement, and it seems to work. So I'll show you a few cases. So this is an abutment level cemented restoration done in the anterior zone, and this is where we actually excel with this particular technique. So you have a patient here who has a fractured central incisors, and a lot of things are challenging. So those who do implantology routinely will understand the challenges here with the anterior implant restoration. There is a very high lip line. There is thin biotype. All these things making. So this is the high lip line, very thin biotype, making any implant restoration a little difficult. And this is again a patient who's flying off abroad to the US in the next 3 days. So my work is cut out. So you have to be very, very careful in what you choose to do with such kind of a case, and make sure that obviously they don't want any trouble over there, and you don't want frantic calls from them or their parents, saying that this whatever you did came out or has fallen off or is shaking. That is a nightmare for an implantologist. Because there are only you can do your best and then you can pray. That's all, right? So this is a case where almost this is like now 6 years back. So socket shield or partial extraction therapy was very new then, but I decided to try that technique here. And you see that there is a bulky root with a very, very thin facial bone, and all the good reasons to employ this socket shield technique. So we split the tooth horizontally, removed the palatal fragment, inserted the implant. The adjacent tooth had an old PFM crown, which luckily the patient also decided to change. And that made my life very easy, because it's, how it is, matching a single central incisors is one of the biggest challenges in prosthodontics. And when you have two central incisors, your life becomes far more easier. And then I put a stock zirconia abutment. So Praveen talked about the advantages of having a tooth colored abutment. So it could be either in zirconia or with a tie base, it could be in lithium disilicate as well. So this was a stock zirconia abutment, which is only meant to be used in the anterior zone. And this was the case with the stock abutment, the partial extraction done, and the adjacent natural tooth had some discoloration on it, and I wanted to use feldspathic ceramic material here. And as you know that they are very translucent, so I need to mask that discoloration. So this was done by painting it with a composite opaquer. And then I had a chairside CAD cam with me now for more than 12 years. And that was a time because the time to complete this treatment was very, very short. And I couldn't have put this burden on a laboratory because they possibly couldn't have completed in that given time. And this was a design on the software, and these were two milled feldspathic ceramic crowns, one on the implant abutment, stock abutment, and other on the natural tooth. So notice the gingival zenith of these two on the day of surgery. This is on the day of surgery when this was completed. So the patient then goes and comes back on the third day to show me, and this is how he looked right before, just after 2 days of the surgery, right before he left for the United States. And he was not to come for the next 2 years minimum because he was studying up there, and it's very, very difficult for them to make frequent trips. So mark the zenith then. So those who do routine anterior implant cases will know that these cases look spectacular on the day of surgery or maybe within a week after surgery. But the real test of your skill, your treatment planning, and your execution remains to be seen after 6 months or a year or a couple of years, right? So I was very anxious to know how this case would turn out. And after 2 years, this patient comes back, and I see a happy picture. Everything is in place. So the advantage here, and to my surprise, there was a coronal migration of the gingival zenith, which is considered to be a unique achievement in implantology and a very desirable achievement. But as a prosthodontist, I would have liked the zeniths to be at the same level, especially for the central incisors. And I even offered the patient to do a little bit of laser gingivoplasty, which he refused. He said that I'm perfectly happy with what I have. So what really worked here are two concepts which we try and follow today in implantology. The one is one abutment, one time. So the philosophy behind here is to connect the final abutment on the day of surgery and never disengage it as far as possible, right? Unless there is a reason for you to. Now, to facilitate this, obviously, you must have the necessary primary stability and all the necessary parameters to load this implant immediately. But when you have this is going to be an excellent technique, because the hemidesmosomal attachments which occur around the implant abutment will stay extremely stable throughout the lifetime, regardless of the labial bone that you have. Even if you have a thin labial cortical bone, which is so much of GBR and grafting and augmentation is done in order to reinforce that. But this simple technique works, and plus we delivered a highly polished restoration. So as Praveen talked about the critical and the subcritical contours of the abutment, even the polishing or the finish on the cervical 1/3 of the restoration that you deliver immediately has a profound influence in the final result of the restoration. So this is a cemented restoration, for your information. It's not a screw retained restoration. And this was the gingival condition after 2 years. So as implantologists, we should not look at the white only, especially we as prosthodontists are so trained to look at the teeth only. But now we all have enhanced our skills, and we are looking at the gingiva because it makes a profound influence on the longevity of the implant treatment. This is after 5 years, and you can see that everything is absolutely stable. This entire procedure was done in 1.5 hours in one single day, one single sitting. Nothing was done after that. So this is the power of even cemented prostheses, which is doable. So what is here, as an advantage is, of course, the simplicity of the procedure. Instead of taking a scan and milling it chairside, if you don't have that facility, you can always get that crown made by the lab, which can be delivered nowadays within a day or two. Then, of course, you may have to temporize the case, but then you use very simple things. You use a stock zirconia, a stock ceramic abutment, and you give a crown, and still you have excellent success with it. But apart from this, the predominant way of restoring implants was using a combination of cement and screw retention. And Praveen already mentioned about the SCRP, which is the screw cement retained prosthesis. And a simple premise here is to take advantages of both these techniques. So you have again a stock abutment being used here, which is milled and modified in the laboratory. And then you prepare a superstructure in whatever material that you choose, right from PFM to zirconia to lithium disilicate. And then there is an access hole provided on the occlusal surface of these restoration. And it is bonded, it can be bonded onto the abutments, either on the model after taking a trial, when you ensure that it is fitting perfectly the same way as it was fitting on the model, or the way I prefer is to bond it in the mouth of the patient after fitting the abutment to ensure passivity. Because when you cement it on your models, there is always a possibility that the distortion due to the impression making that might have resulted will cause a little bit of minor misfit when this type of prosthesis is again brought onto in the mouth of the patient. So as Praveen really mentioned at the beginning of his presentation, passivity is paramount in success of any implant restoration. And whatever abutment system that you choose, the primary requirement that it should have a passive retention. It should have passive prosthesis performance with relation to its attachment or connection with the implant. You cannot have active connection, because especially in delayed loading, because that will result in generation of stresses at the implant bone junction, and which will usually result in some crestal bone loss. So this is one of the most popular way of processing implant restoration, especially single, but even multiple, whereby an advantage is taken by using the stock abutment, which is already present in your cupboard in large numbers. You try and choose the correct gingival height, the correct angulation as per the need of the case. And the laboratory will then fabricate a crown or a restoration, which in the same way as they do on a natural teeth, and they will ensure that it fits well on the model. You can double check this in the patient's mouth, and then you bond it. One thing which I forgot to tell you, that I prefer to bond it in the patient's mouth, but I immediately after setting of the cement, I remove the entire assembly out and make sure that there is no excess cement at the junction of the crown and the abutment margin. Clean that thoroughly, polish that. You spend some time in finishing and polishing that. You might have if you particularly see under magnification, you might see a slight opening at the margin, which you can seal at this stage using composite resin, and then polish the entire margin properly, and then retorque it back onto the implant. So this is a highly recommended technique where you can have the best of the both worlds. You can ensure good passivity because you have cemented the crown in the patient's mouth where it is supposed to perform. And after that, you have not left it as it is. You have removed it, for one, to make sure that it will be retrievable in the future. You need to test it right on the day of delivery. Sometimes the access hole may be inadequate. Your hex driver may not engage completely the head of the screw. So this is the time where you can change that. You can use a burr to enlarge the hole or modify it a little bit to ensure that there is no debris in between, or there is a straight line access for the hex driver tip to reach the head of the screw. Remove that assembly, clean it thoroughly, finish and polish it, and deliver. So this is a very successful technique, especially in our country, where cost is always a factor, whether you like it or not. You can go to the highest level of customization There are a lot of companies which provide very high-end custom abutment solutions, but it always comes with a cost. And to be fair to our patients, we try and give them something which is also cost effective. There's nothing wrong in it as long as we do all the things right, and we do not compromise on the final result. So you see there are good success in using this technique. So this is a SCRP again for single restoration and using engaging connection. So Praveen mentioned about engaging and non-engaging abutments. I had also included a little bit of that, but then I took it out of my presentation because he had already covered it. So when you work on a single tooth, remember you need to use an engaging connection for a very simple reason that there has to be an anti-rotational feature present in your connection. Otherwise, your crown will be free to rotate and it will happen slowly. It may not it may feel very firm on the day of delivery, but be rest assured that in the coming weeks or months, it will, under the occlusal loading, it will start to move or slip, or there will be a play created between the implant abutment connection, and then slowly it will either lead to the screw loosening, which is a more favorable complication, if you like, because it can be easily corrected. But sometimes it can lead to fracture of the screw and loss of the entire restoration. Right. But on the other hand, when you work with multiple implants and you want to give a bridge, whether it is joint crowns or three unit bridge, or even more a longish span, longer a span, then you would like to use a non-engaging connection, because as Praveen explained, the path of insertion, no matter how parallel they look to us on the X-ray, there is always some variation, especially when you do freehand placement between the 2 or 3 implants that you want to restore. And it is better to have a multiple path of insertion and removal, so that there is no engagement or stresses created at the implant abutment junction, and again leading to an active stress situation which will lead to progressive crestal bone loss. Right? So just to show you a case of the cement screw retained crowns or restoration. So these are multiple implants, and as you can see on the picture, they are non-engaging abutments. So they have no anti-rotational feature, no hex, no spline, or no Torx type of connection, depending on the implant system that you use. So most implant companies will have these kind of abutments in their portfolio. So my suggestion and recommendation to you all is to sit and study their catalog, although it is very boring and sometimes can get very monotonous to go through a number of pictures. But at least a good implant system should have these possibilities, should have this available with them, the possibility of using a non-engaging abutment. So this is one of the easiest way of dealing with multiple implants in a real life clinical scenario where the parallelism may not be 100%. It never is. And this takes out a lot of stress from the implant abutment junction and makes your life easy. It's easy for you to place the prosthesis. There are no surprises. It is easy for the laboratory to fabricate them because they don't have to make any adjustments. They don't have to manipulate the connection of any abutment in order to ensure a smooth path of insertion and removal. So this is the clinical case. So all the posterior teeth that you see are, this is on the day of delivery, and with zirconia, which is an excellent tissue-friendly material as the superstructure. We have nice adaptation of the mucosa around these implant prostheses, right? And this is a radiograph showing the same. So no matter which implant system you use, in cases of multiple implants, we try and use non-engaging abutments, and we can still work with the screw cementable type of retention, where we have modified stock abutments, which on which the prosthesis is made, and then it is tried in the mouth. It is preferably cemented on the abutments in the patient's mouth, and then the entire assembly is removed and then finished, like I have explained, and then torqued back. So now we come to the need of a stock abutment. We were, as you saw, we were not really very unhappy, if I may say so, with the stock abutment, but there are situations where they simply don't work. For example, if you see this clinical case on the model, you see that the implant position has gone quite more distally as opposed to what it should have been. So again, as Praveen said right in the beginning of his presentation, your life will become very easy prosthetically if your implant is in the correct position. And this is the reason why implantologists all over the world are slowly going towards guided surgery and guided placements, not only for full arch cases, but also for single teeth replacement. Now, experienced implantologist many times wonders what is the need of using a surgical guide for a single implant case, which he or she has been doing for many decades. But even with your expert hand, your judgment, it is still possible that even a minor variation anterior posteriorly or buccolingually can really affect the quality of the prosthesis that is going to be delivered to the patient. And always remember that patient has come to you for aesthetic and functional replacement of their missing teeth. And as long as you should strive in order to make sure that the implant prosthesis looks and feels exactly like a natural tooth. Okay, it doesn't look like an artificial tooth. So these were the issues that we faced with stock abutment. Now, the advantages of stock abutment was that it was very easily available, as I explained that they usually came in huge numbers along with the implant that we bought. They are cheap. Let us make no mistake that in our country it is an important factor. And being a part of a dental laboratory, I know the laboratory side of it, and I know how it is, how difficult it is to convince a dentist that this treatment protocol where we used a customized abutment is much more favorable for the case, favorable for the patient, but it will come with a price. And the moment you talk about price, many dentists, I may not say all, but many dentists overrule that, and they just say that we had not quoted that much to the patient, and I cannot spend some more just because there's a better mechanism available. All these years we were managing with stock abutments, and I think we should continue the same. So my recommendation or my say is that now we should spend less on the implant and try to spend more on the prosthesis. And a big part of that, a good prosthesis is in the abutment that we choose, the type of abutment, the material, and the technology that is used in order to fabricate. Okay, so there is no one answer that you should use this type of abutment only. I will never say that you should use only custom abutments for all of your rest of your cases in future. But as per the need of the case, we must be open to accepting some customization of your abutments rather than always using a stock abutment. Right? And another, of course, important advantage of using stock abutment was that it was very easy to fabricate by the laboratory. And because they were making natural teeth restoration, the transition from there to making cemented or screw cemented restoration was very easy, because finally they had a abutment which was analogous to a prepared natural tooth, and they had to prepare a restoration on it, which was extremely easy for them. And one very big technical advantage, which I feel still lies very strongly in favor of a stock abutment, is that it is pre-manufactured. So as Praveen told in his take-home points, the last point was to use original components as far as possible. And stock abutment always has been a original component, because it has come along with the implant made by the same manufacturer, and it has a connection which is perfectly mated to the internal surface of the implant. The material used is already researched and has been found to be perfectly adapting with the implant system. So you are very safe as long as the correctness of the technique is concerned as far as the implant abutment connection goes. So you will never make a mistake in using a stock abutment in compromising the implant abutment connection. Now, the question is whether the part of the abutment above the connection is going to help you to give a permanent, long-term, durable prosthesis or not. So we all have seen the problems with stock abutments. Of course, the first is poorly fitting crown margins because they were prepared by the analog technique. Initially, they were prepared by casting. Like I mentioned, the same technique which was used to fabricate natural teeth restoration was also extended to the implant arena, and they started just making wax pattern on it, casting, and then giving crowns on them. Many laboratories still do this, but if you are a conscientious implantologist, especially a prosthodontist, you should do away with casting at all as far as implantology is concerned. There is no place for casting as a processing technique in implantology. We have far better techniques like CAD/CAM, we have milling, we have laser sintering, DMLS, which is an excellent way of creating passive, lightweight, frameworks, whether it is for single tooth or for multiple implant case, in materials which are much better. You can use cobalt chromium instead of nickel chromium, and you should shift completely. Even if it is a single crown and you wish to give a PFM restoration on a single implant crown, it should be done with DMLS, which is layered and not with casting, right? And of course, the other problem was overhanging restorations because the wax patterns were either made directly on the abutment, or even if they were scanned, the scanners could not penetrate till the margin, and many labs did not modify the stock abutment to an extent where they could have perfect margins, because ideally they are supposed to use a surveyor with a handpiece mounted on it, but very few labs actually go down to do that. So we always had overhanging margins or sometimes short margins, as you see on this X-ray. This is a common sight, and those who have been practicing implantology for many years, if you go back to your old cases and pull out their X-rays, you will find that many of them look like this. So this is one reason why we try and avoid stock abutments. One solution given by some implant manufacturers is to give you some wide profile abutments. Now, these are particularly useful for posterior teeth, where you find that the standard stock abutment is very narrow and circular in dimension. Now, having said that, even these are circular in their perimeter, but at least they have a wide profile, which will allow you to give a better emergence profile in the final crown. So here you see a case of a wide profile abutment. As you can see, it has a broad diameter and a margin which is much broader. So mesiodistally, the abutment tries and cover much more area than a thin, narrow stock abutment would have done, right? So you have the ability to improve the emergence profile of your implant restoration by using these kind of wide abutments. So then again, I would really encourage all of you to check the catalogs of your implant manufacturer and try and see whether they provide. Many times it is not readily available because very few dentists have ordered it in the past. But if you request for it, they will arrange for it, and it should be costing you almost the same as any other stock abutment. So this was the way it was processed. You have a wide abutment and a crown is placed, and this is how it will look like on the radiograph. So this also helps to solve some of our problems. So in a way, this is slightly better than using the standard stock abutment, where you have some degree of customization. I wouldn't say it is completely customized, but something better than using just a narrow stock abutment and improving the emergence profile of your implant crowns. Now, when we talk about emergence profiles, the ideal emergence profile, that is then, emergence angle of the implant restoration should be 33 degrees, as you see on the picture on your right. This is only possible when the implant coronoapically is also placed in the optimal position. So nowadays, the recommendation is to submerge most rough surface implants by at least 1 to 1.5 or 2 millimeters. Now, this allows you a lot of space, restorative space, in order to achieve an ideal emergence profile. But many times we do not foresee this, especially cases with reduced, vertical space, vertical restorative space, and we tend to miss out on this opportunity where during the surgery you could have submerged the implant. There are times where we even reduce the crest of the bone and then submerge the implant further down so that we create actual space for the crown. And if you fail to plan this, sometimes you're left with a implant which is right at the crest and you have very little vertical restorative space, and then it is impossible in this case to achieve ideal emergence profile. And no matter what you do, if you try and customize your abutments, it will still have issues with hygiene maintenance and less than ideal gingival embrasures mesially and distally, right? So the basic advantage of using a customized abutment, regardless of the technique used, is the perfection of the fit between the superstructure and the base. So either it is a completely milled prosthesis, which is made up of titanium. Also, it was available with zirconia, but zirconia connection is not recommended anymore, except for very few anterior cases. But or the second type of customization is, of course, using tie bases, which we will discuss in detail as we go further. But one thing which is really common between these two protocols is the perfection of fit. So you never have to worry about overhanging margins. You never have to worry about open margins, because they are digitally produced and they are absolutely perfect in their profile. So once the restoration is stocked onto the implant, there is zero possibility of micro leakage or any kind of irritation that it might cause because of a less than ideal contour of the cervical 1/3 or the emergence profile. So which brings us to the era or the topic of customized abutment. So as we discussed, you could either go for the stock, or better would be go for a customization. Does that mean that the old is lost? No, old still has its place. So always remember, take your call depending on the need of the case and not because somebody has been propagating one type of technique to you. Right? So the original customized abutment were the UCLA abutments. These were available with almost all implant systems. And as Praveen had mentioned that this could be engaging or non-engaging, they always came with a castable cylinder on top of them. And the idea was extremely good. And I'm very happy that the department of implantology at UCLA had thought of this problem. And this was the first customization that this was available 30 years back, right? The first customization which was possible on implant abutments, where the connection was pre-manufactured by the manufacturer. So there is no risk of incompatibility or ill fit between the restoration and the implant. But it was possible to customize the superstructure. Those were the days we did not have CAD/CAM, so the only technique available was casting, and a metal framework could have been casted using these castable patterns or castable cylinders. So wax patterns were developed on these cylinders, and they were cast, and then they were bonded onto the either bonded onto the connection part, or they were casted directly onto there were techniques where thereby casted. So this was made up of gold alloys also, which was very favorable for casting gold alloys onto these kind of UCLA abutments, right? So this had a lot of success, and this was basically developed to solve the problem of labial screw access in anterior teeth, but it was extended to the posterior segment, and a lot of almost all implant systems adapted this technique. Unfortunately, in our country, this saw limited success, because by the time implants started becoming popular and people understood the various combination, CAD/CAM came in, and that really revolutionized and made this particular component actually redundant now. So what are the types of custom abutments that are available today? The first, of course, is one of the most popular, one of the most successful and highly recommended type of customized abutment, which is the milled titanium. So as you see here, this entire abutment is completely milled and processed by the laboratory, including the connection. So depending on the implant system that you use, either you take a scan using a scan body of that particular system and send your file to the laboratory, whereby it is imported into softwares like Exocad, and from its library, your implant system is usually present into the library, and they select, and they can actually manufacture this. Laboratory can manufacture this abutment out of a blank of titanium, right? So this is one of the most popular and one of the most successful types of customized abutment. Second, of course, is milled zirconia. Now, this was done about 2 decades back, or maybe 15 years back, but immediately they found that there is a problem. Obviously, zirconia is being brittle. The connection had a lot of stresses, and the implant abutment connection would break off, leading to catastrophic failure of the restoration. Some type of milled zirconia is still used in a few zirconia anterior cases, but I would not recommend it at all, even for that, because we have better options. We had the hybrid zirconia, lithium disilicate, or PEEK. So the second one would be PEEK. So this is basically the tie-based system, where you have a pre-manufactured abutment, which is called as a tie base, onto which a superstructure is then customized using either zirconia, lithium disilicate, or of course PEEK. PEEK is polyether ether ketone. It's a bionic material, a very unique material, which has a modulus of elasticity, which is almost exactly same as the bone, and it is highly inert material, light material. It's a polymer. So a lot of implantologists are shifting to PEEK as a abutment as well as a framework material, right? So you are going to see a lot of this in the future as well. Now, when we see literature on the fracture resistance of titanium, zirconia, and even the PEEK material and lithium disilicate, we find that the PEEK ceramic PEEK abutments can be an alternative to titanium for single implant restoration. This is the key. Now, see, their recommendation is only for single anterior restoration. They still are not sure whether it will work the same way on the posterior implant crowns, right? So at the moment, we should try and stick to using these modern materials for anterior restoration, although a lot of implantologists are routinely using this combination for posterior crowns as well, but mainly limited to single teeth restoration. Now, literature is still coming in, and as a conscientious implantologist or prosthodontist, we should at least await for a 5-year result, which firmly says that with a lot of evidence that it is working for the posterior. But we already know that we have ample of evidence for titanium, and this is what is going to work very well. So if you compare a tie base with a fully milled customized abutment, this is the difference. So in the first row, you see the middle row in this the middle column, is of the tie base, where you find that at the bottom is the implant. Over that is the titanium base, which is a highly specialized pre-manufactured abutment provided by your implant company. Over that, you fabricate a superstructure, either in zirconia, lithium disilicate, or even in PEEK, and it is then bonded onto that tie base extraorally in the laboratory. Okay, we'll see that protocol as well. And of course, there is a screw to retain everything. So ultimately, after bonding, it becomes a single unit. You have the superstructure and the tie base becoming a single unit, and then it gets converted into a screw retained abutment, over which the final superstructure, that is the final crown, is fabricated again with the material of your choice. And if you see the third column on your right, that is the customized titanium abutment, where the entire abutment, including its connection, is milled by the laboratory. And obviously, there is a screw, and all you need to fabricate is the superstructure, again in the choice of material that you wish. So all in all, the fully milled titanium abutment is a much simpler protocol. but we will discuss why sometimes that can be a little bit of a problem, and why in most cases, if I may say so, most, not all, but most cases, we try and choose a tie-based concept which caters to almost every situation that we come across in implantology, right? So this brings us to one of the great combinations, great technique called as pre-milled abutments. In this technique, we have the best of both worlds. So we have the connection which we have been talking about, that we should try and use original components. So we have the connection which is manufactured by the manufacturer of the implant system that you use, but the superstructure which is going to be in titanium, which is going to be a single piece continuation of that connection, is customized by the dental laboratory using their milling machine, right? So this is a great option which is available, pre-milled abutments, and basically it allows you to have a perfect implant abutment connection interface, and at the same time customize the superstructure in titanium, which we saw is one of the most successful ways of making customized abutment. So if you see pre-milled abutments, they basically look like this in the laboratory, and it is like a huge cylinder with a connection right at the end of it. So in the laboratory, the technician will choose the implant system and choose the pre-milled abutment option on the software, and whatever the case you design is, then the machine will start, the 5-axis machine will start milling it and customizing from the connection upwards. It is not going to touch the connection part at all. It will start milling from the junction, and it will go on milling and milling and milling as per the design. And finally, from there, you see almost like a customized abutment, and this is the final result. So if you see on your right hand side, the connection was pre-manufactured, and the rest on the middle and the left hand side was customized in the laboratory using the laboratory's 5-axis milling machine. The same can be done on PEEK as well. So this is a elegance abutment which has the connection which is prefabricated by the manufacturer. So, and the superstructure is made up in PEEK material which can be customized. So now you can have a pre-milled titanium or a pre-milled PEEK abutment. So this is how it looks like either on the model. So you can see these abutments are customized, and you can have in PEEK material, and you can have a nice combination of a perfect connection and a superstructure which is customized. This can be, of course, extended to full mouth cases where you can have each and every abutment which is now customized to the need of the case, rather than using either multi-unit system for whatever reason you do not wish to use multi-unit system. You can still make customized abutment for each and every implant that you have placed. The downside is, of course, it comes with a cost. It is expensive, and as expensive that sometimes the cost of the prosthetic treatment surpasses or becomes even twice of the implant surgery, which many implantologists don't like, because basically they feel that their surgical skills in placing the implants was the gist of the entire treatment, and the prosthesis the laboratory should make is as cheap as possible, because we can't really charge the patient for it. But if you think rationally, it is the prosthesis which actually makes all the difference in the final result of the case, and you should spend more of your time, your energy, and your money on making sure that you get a high quality prosthesis, because the patient can see the prosthesis, feel the prosthesis all the time, but they cannot see your implant which are inside the bone, right? So this is where, so this schematic diagram clearly shows in cross section the difference between the stock abutment on your left and the custom abutment on your right, and you can see clearly how easily can the gingival margins be adapted, fully knowing that the gingival margin in real life situation is not at the same level in a case. It can be higher on the buccal side, lower on the lingual side, higher on the mesial, lower on the distal. And when you use a customized abutment option, you can design your abutment with a margin which is matching the contour or zenith of the gingiva as in the patient's case. So all this exercise is basically to achieve a better emergence profile, because at the end of the day, like I said, an implant crown should look as if it is growing from the tissues or from the gingiva, not as if it is kept like a artificial thing on the gingiva. So this makes all the difference in the success. So it is not just the look of it, but it is the fact that when it has a narrow emergence profile, there is a lot of food lodgement and food accumulation beneath the contour of the crown, and the patient is never happy. When they move their tongue around that crown, they can always feel that depression, and they keep on complaining right from the day when it was placed, and it is cumbersome. So we try and tell them that it is an artificial tooth, artificial crown. It cannot be same as a natural tooth. But actually we are wrong. Today we have the techniques, we have the materials, we have the technology to give them an implant crown which feels, looks, and performs almost like a natural tooth, right? So you should strive and do everything possible in order to achieve that. So here we see a clinical case. So on the top left, you see a stock abutment, and you can easily relate with this picture, because this is the kind of scenario we have been doing for so many years, where we put the stock abutment. And on the bottom left, you see the crown which is made on the stock abutment. So now you can see how it looks like an artificial crown. It doesn't match with the rest of the teeth. It looks narrow at the bottom. It is constricted in its near its neck, because that is where the margin of the circular stock abutment is. So technician is forced to end the margin and match it with whatever is available on that thin narrow abutment. And he will try to customize the occlusal surface of the crown to match the rest of the teeth, which is sometimes impossible. So mesial distal, obviously contacts are closed, but buccolingually you will find that the crowns do not look like a natural teeth at all. As opposed to that, on the right hand side, on the top right, you see a customized abutment, and there you see clearly how better the entire circumference or perimeter of the abutment is, how it is matching closely to the tooth it is going to replace. And when you see on the bottom right, you see the same crown in the same region, being on the same implant, being placed with a custom abutment, and the crown now very closely resembles that of a natural tooth. It is so easy to achieve an excellent emergence profile here, and all the issues that we have of food lodgements on the lingual or the palatal side of such kind of crowns is addressed. So this simply shows you the advantage of using a custom abutment. Also on the model, similar cases on the left. I'm so sorry that the bottom picture is switched. It should be right on the left, but on the upper left you see a stock abutment which is narrow, which has been milled. The height has been reduced to get occlusal clearance, and you can see how narrow it looks. And the crown, unfortunately, I apologize, on the bottom right side. So that is the crown conforming to the stock abutment. On the right side, top right side, you see a custom abutment, and you can see how much bigger and favorable it looks, how supportive it looks from all dimensions, from the mesiodistal aspect, from the buccolingual aspect, right? And on the bottom left is the crown which will fit on that particular custom abutment. So you can see clearly the difference in the contour. So occlusally, we could match the contour of your crowns with a stock abutment, but it was the cervical 1/3 where things went wrong. All these crowns made on the stock abutment were so constricted that they made the contours highly unfavorable, and hygiene maintenance a big task and challenge for the patient. So what are the advantages of using a custom abutment? It always helps us to achieve a passive fit, because if either you mill the crown in titanium, or you use a titanium base. Here titanium base rates even better than a milled titanium abutment, because you have a pre-manufactured base on which you have customized the superstructure. So passivity is almost guaranteed. Then, like we have been talking about, it helps us to achieve optimal emergence profile. Now, this is something which we really should work on hard, because we have been making single implant crowns or implant bridges on multiple implants for many years. But go and check your old cases where you go and try and ascertain the emergence profile that they provide, and how can we improve it? How can I make my crown look like a natural tooth? How can another dentist, who for whatever reason the patient goes to, will never be able to identify my implant crown unless he takes an radiograph, right? So this should be your aim. It is far more easier to correct improper angulations of implants when we customize our abutment, because although we have the possibility of using angulated stock abutment, which comes in either 15 degrees, 25 degrees, and in some cases even 35 degrees, but it is never accurate. It is always a range. Sometimes we want maybe 12 degrees, which is, or we want 23 degrees or 19 degrees. So when we use a customized option, we can devise or design your abutment exactly as per the need of the case, right? And of course, last but not least, when you have a custom abutment, you have less work to do chair side, because these restorations, these abutments fit perfectly. Their margins are perfect. The restorations, margin of the restoration match with that of the abutment perfectly. And you can save a lot of unnecessary chair side adjustment time, when you deliver these kind of restorations. So another advantage of using customized abutment is the ability to customize the gingival margin. Now, this is never possible in a stock abutment, although there are certain companies which do provide anatomic abutments which have slightly variable gingival collar height, but it is not customized, right? It is just another option, maybe slightly better than using just a uniform circular margin, but nothing can compare to the ability to actually customize the abutment exactly as per the need of the case. So, which is only possible when you use customizable. Now, one reason which I always talk about, which very few technicians and experts will tell you, is the real reason behind using pre-manufactured components instead of getting them milled in the laboratory. So you all know that most dental laboratories today who are manufacturing implant crowns or implant restorations have CAD/CAM with them. Every lab that you go in will have a CAD/CAM machine. But there is a difference in the nature and the quality of these machines. So typically what you find in a dental laboratory will be a machine which is a 5-axis machine. It has dry and wet milling capability, and it costs somewhere under 50 lakh rupees, right? But if you go to an implant company and see actual manufacturing of dental implants and their components, they also use CNC milling machines. Okay, they are also milling machines, but they are 7-axis and in some cases 9-axis milling machines, and they cost over 5 crores of rupees. Right? So obviously there is a difference between that sophisticated machine and what your dental laboratory is using. So if it was the same, if there was no difference between these two kind of, the quality of machines and the result that they produce, most manufacturers would have gone for the cheaper machines because it saves a lot of cost and maintenance, right? They would have made more profit out of it. So the reason why they employ these better machines is because the precision obtained is far better. The tolerances between the implant components and the implant is perfect, or it is very much within the acceptable limit. Even a 5-axis machine which costs anything around 30 lakh rupees can also mill metal. It can mill metal. It can mill titanium. Your dental technician will tell you that, I will give you a customized titanium abutment, and when it is prepared, it comes to your clinic. There is a crown fabricated on it. When you fit it, it looks it feels more or less perfect. But if you are very careful in observing that there sometimes can be a little bit of play between the abutment and the crown. So there is a play. It doesn't feel the same kind of snap fit which you observe with a pre-manufactured titanium abutment, right? So there is a difference between these machines. They will work well for a while, but in the long run, sometimes because of this slight errors between the abutment surface and the implant surface, and the occlusal loading that the abutment experiences over a period of time, there can be a mismatch and there can be a slight micro motion between them, which begins and then slowly increases in dimension. The patient may not notice it initially, but sometimes they come with a complaint that your crown is shaking. Sometimes they ignore it and they start getting food lodgement. They ignore that as well, and it leads to caries on the adjacent natural teeth, which is a very, very common observation seen on posterior single crowns, around posterior single implant crowns, right? So one of the reason is the incompatibility of fit. So you should, if you really want to make a excellent fully milled titanium abutment, you should find out which kind of milling machine the technician is using, and try out a couple of cases and see how good the fit is. Otherwise, the safer option is to either go for a pre-milled abutment, which we have already seen in the earlier slides, where the connection is made by the manufacturer, and all that the laboratory needs to do is to mill the super, not the superstructure, but the rest of the coronal part, which is easily doable by any machine that most of these labs have. So that is not a problem. Or the second option is to go for a tie-based concept, which we are going to see next. Right? So we come to the titanium base, and this is a elegant solution to give us an easy option for most of our implant cases. So what is the titanium base? It is basically a specialized abutment, if you like, which is made to allow customization onto them, right? So one thing is already taken care of, that the connection of this system is pre-manufactured by your implant system, and that is where you don't have to work on the connection at all, nor the laboratory has to manipulate it. Okay, it is pre-selected, it is pre-manufactured. All you need to do is to customize the superstructure of it. So when we talk about tie bases, they could be available at implant level restoration and for multi-units. So you have scan bodies available from your implant system, which is for implant level. So you anchor these scan bodies directly onto the implant and take your intraoral scan. Or they could be for multi-unit abutments, whereby these kind of scan bodies will fit onto the multi-unit abutment and then allowing you to take a scan. Now, matching with that, you have either the implant level tie bases. So these are available in various gingival heights, which is a good thing. And all you need to do is to take a scan using the implant level intraoral scan body. And in the laboratory, the lab can then use the gingival height which is most favorable for their case. They will 3D print a model. They will use a digital analog, so which we will see further. So along with the implant level tie bases, you have the abutment level tie bases, which go and fit onto the multi-unit abutment, allowing you to customize superstructure on them. Then the last part, of course, is very important. They are the digital analogs. These analogs are not the lab analogs which are used with your gypsum models. These are specialized analogs which are meant to be fitted in on 3D printed models only. And they, if everything goes well, if the lab is using a good quality printer, a good quality resin, these usually fit directly, snap fit. They snap fit. They just have to be pushed and they friction lock into the socket created by 3D printing by the software, right? And in some implant system, they can be screwed onto the cast also, or the 3D printed model. So again, the digital analogs come in at implant level and they come at abutment. So again, if you see the catalogs of your implant company which you use, the latest and the newer catalog, they will always have a digital section where they have all these, the available scan bodies, the tie bases, and the digital analogs. So you can have an intraoral scan body, or you can have an extraoral scan body. So as the name suggests, intraoral scan body is used in the mouth. Why do you think it is different? It is basically the same thing, only the height is different. Because intraorally, it may be sometimes challenging to use a very tall scan body in the posterior area because of lack of mouth opening, right? So they have devised smaller scan bodies which are easy to scan in the mouth. Whereas in a dental laboratory, it is not a problem because you have everything is open, and the scanner is also, now their architecture is very open, and you can scan by allowing a larger length scan body. And then of course you can customize the superstructure and bond it. Now good implant systems will have tie bases. These are tie bases, titanium bases, in various gingival heights. So this is a very useful feature. So if you observe carefully, from these 4 tie bases, all of them have the gingival portion, which is the connection, which is exactly the same, and which have the coronal portion, which is also exactly the same. The only thing that is varying is the gingival height. So we start from in this, it is 0.8, but it is usually 1 millimeter. Then there is GH2, then GH3, and GH4. So this is a good option because then you can cater to a number of different cases, scenarios, by using the correct gingival height. So once your scan, which looks like this STL file, goes to the dental laboratory, and they import it in their software, which is usually ExoCAD, and on them they design your restoration. It could be either a monolithic zirconia crown, or it could be a framework for a PFM restoration, which will be laser sintered later. And you see, this is the design here by maintaining the screw access and screw channel here, right? And this is the screw channel on the restoration, which is maintained. This is the full crown on your upper left, and on the right side, it is customized to allow layering. So it is cut back digitally to allow space for the layering material. And this is the finished product. And this is how a customized abutment can look like. So all you need to do is to remove the gingival former in the patient's mouth, attach your intraoral scan bodies, and take a scan. Send the scan to the laboratory instantly online, and put the gingival former back. You are done. Rest everything is done by the laboratory, where they import it. They will design it on this virtual model and send it for manufacturing, but they will 3D print a model so that this can be verified, its fit can be verified on the 3D printed model, and also will facilitate layering in case you have chosen that option. So this is a picture. These are the 2 sizes of scan bodies that are available. So why have I used the 2? Because I had one short and one long. So I use that, but it clearly shows that both work. Only thing is the technician has to be smart enough to choose the appropriate scan body in their library. Okay, if he chooses both small, then there is going to be a problem. There can be a vertical difference between the actual and the what is available on the model. Okay, restoration height can change. So your technician still has to be very smart. Just because we have digital technology doesn't mean that the skill and the awareness of the technician is gone less. In fact, on the other hand, it becomes the need for them to be very sharp becomes even more, right? So they have to be more skilled and more aware. So this is the the superstructure milled in zirconia, and then it is bonded onto the tie bases, hereby converting them into a screw retained crown. So this is the radiograph of that seated, perfectly seated. Another example, you have the tie base at the bottom, and you have the crown which is cemented onto the tie base extraorally. Now the best part is when you do extraoral cementation, you remove entirely the risk of the cement entering the gingival peri-implant sulcus or mucosa, right? So this is the final restoration which is stocked in place, right? A zirconia restoration made by. Now on the chair side, CAD/CAM system, those of you who are interested, also has this tie base concept which works beautifully. So in this case, you have a titanium tie base which is conforming to the implant system that you are using. Instead of the tie base, you can use a scan post. This scan post is used when you have a lot of thickness of gingiva over the implant crest, and you want to, if you put the tie base onto the implant, it gets completely buried inside, and you can't see anything, and nor can your scanner actually scan over it. So to alleviate this problem, they have given a scan post which is much taller, and it extends out of the gingival sulcus clearly. Then you have this scan body, which are made up of PEEK material, which is reusable, which is put onto the tie base or the scan post before scanning. And as you notice, there is a slot which is seen on the surface. It has to be that slot. The slot has to be matched with the one which is present on the tie base or the scan. So this is one thing you need to do before you start scanning. And then after that, of course, the life is very easy. And last but not least, you require ceramic blocks of various materials like lithium disilicate or zirconia, which has a hole in the center, as you can clearly see, because these are meant to be used for the tie base protocol. And after bonding this superstructure made out of these blocks, they will get converted into a screw retained prosthesis, right? So we use some specialized cement, as Praveen mentioned in his presentation, that the laboratory uses ideally some specialized implant hybrid cements which are used for this purpose, for the purpose of cementing or bonding superstructure onto the tie bases, right? So whether it is the lithium disilicate or whether it is zirconia, these kind of specialized cements are used. They come as in the translucent variety and even in opaque variety. The opaque variety being preferable because they can mask to certain extent the darkness of the metallic tie bases. So these tie bases are typically sandblasted and they are surface treated, and after which the superstructure, which is also treated according to its content, and then it is cemented. So this is the protocol that you see. I'll make it simpler for you. That it is the titanium base is sandblasted using 110 microns of sand. So the grit of sand is extremely important because the molecular diameter of the cement which is employed for luting them has to match with the surface roughness that is created on the abutment. So ideally you are supposed to use 110 microns, but routinely we use anything between 50 microns and 120 microns, and everything seems to work. But the ideal is that protocol. So once that superstructure is made, you treat the superstructure. So in case it is lithium disilicate, you etch the internal surface of that crown using hydrofluoric acid 4% for 20 seconds, wash thoroughly and silinate. If it is zirconia, we just lightly sandblast the internal surface using 50 micron sand, not 110, 50 micron sand, and then apply a metal zirconia primer onto the internal surface. On the titanium surface, we also apply the metal primer and then use these resin cements to lute them and then finish the junction. Once the cement sets, we can finish any excess cement which is still attached to the implant or the superstructure abutment interface, right? This is better done under magnification. So just to show you this technique again, you have the superstructure made in lithium disilicate and you have the titanium base. You can see from both coronal as well as from the gingival aspect. And here you can see the titanium base is sandblasted. You can clearly see that slot notch which is present on the titanium base. And now the lithium disilicate is etched with hydrofluoric acid, washed, silinated, and using a specialized resin cement, it is fixed onto the tie base. Now, by doing this gets converted into a screw retained prosthesis, right? So several concerns have been made about the strength of this bond. Now, with any bonding technique, the technique is extremely useful. We have to ensure that we use the correct grit of sand when we are sandblasting the titanium abutment. We use the correct grit, that is a 50 microns for sandblasting the zirconia, if that is a superstructure. We follow the correct protocol for lithium disilicate, etching, silination, etc. And when you use all this correctly, the chances of debonding is very, very low because the fitting of these superstructure is very perfect because it uses CAD/CAM technique. So a cement space is already created. So it is not a loose fitting thing. Even if you use a temporary cement, it lasts for many days. So, but if you bond using the correct technique, it is never. So if a debonding occurs, there has been some error in your technique or the technique that the laboratory has followed. So this is how it is cemented extraorally, and you can now clearly see that it gets eventually converted into a screw retained crown. And if you see the clinical application of it, and this is the case seen from occlusal aspect, and this is from the buccal aspect, and you can now the lower, that is the 3/6, the 2/3/6 has been restored by implant crown, and you can see the emergence profile that you achieve when you use a customized abutment. This can never be achieved if we use a stock abutment instead. So another case where you have slightly tilted implant placement, it is not an ideal placement. So if we were to prepare a cement screw retained prosthesis, we would have had to use angulated stock abutment and then customize, but the gingival profile would never have been the same. So when you use a tie base, it allows you correction of up to 15 to 18 degrees deviation in the angle, and then it works fine. So on your right side, you can see the crown, and you can appreciate the emergence profile that is present by using a custom abutment. Similar case, you have the tie base in place, you have a customized abutment, and you can appreciate the emergence profile that you achieve. Two adjacent implant cases, I want to emphasize how favorably the tissue responds to these kind of custom abutment. So there are two separate custom abutments, custom abutment crowns now made. So on the upper left, you see the crowns. On the upper right, you see them immediately after torquing them into the position. And on the lower right, you see a picture which was taken after a couple of years. And then you can see how nicely the gingiva has adapted onto this material. One important tip that I can give you, that when you use another case of two adjacent implants of two different implant systems, dissimilar implant system. This is a real life scenario which many of us face because one implant was placed somewhere else by somebody else, and now the patient comes to you for placing another tooth. Probably they have shifted, they have got transferred. Now they cannot go back to their dentist. They still want to restore. But all you need to do is use the correct scan body or the tie base which is designated for your implant system. The processing technique remains exactly the same, and you can place from the outside. They will look very similar, but these are two different implant systems that have been utilized. Okay? You can here appreciate the gingival emergence of the second molar. The first molar is a very old zirconia crowns, and we knew how ugly they looked at that time on a natural tooth. But 3/7 is the second molar, is an implant crown which is made with lithium disilicate. Now with the guided protocol, it becomes even more simpler. On the first appointment, we just use the surgical guide, place the implant, let the patient go. After 2 or 3 months, the patient comes back, take a scan, and deliver the crown on the second appointment itself, right? So this is by using chairside CAD/CAM, but you can still scan using your scan body, send it to a lab, and probably most labs will be able to give you the crown within a couple of days, if not less. So this is the placement, and you can see how faithfully the surgical guide will allow you to place the implant exactly in the same position, and a post-op CBCT confirms the position of the implant. And it is perfect in a way, but minimally invasive, and you have a restoration that actually looks like a natural tooth, which feels like a natural tooth, and is very durable because you have the access hole coming exactly in the central fossa of the posterior crown. So just to show you, there are various clinical scenarios, all have been addressed. You have varying gingival heights, you have varying vertical restorative space, you have varying mesiodistal space. No matter what situation you come across, you can use a tie-based concept and give a satisfactory crown in each and every case. which is functionally, these are all screw retained crowns. They are retrievable, easily retrievable by the dentist, but they also look and feel like a natural tooth and function like a natural tooth. One additional, advantage of using customized abutment, I know I'm ending, it's about 7 minutes to go, is in immediate extraction cases where we extract a posterior or an anterior tooth and we want to replace it with a implant crown, but we don't want to load it immediately. Okay, we don't want to load it because although we have got good primary stability, if I put a gingival former in this case and allow it to heal for 2 months, we will find that the gingiva will collapse and adapt to that gingival former. It will be absolutely circular. So from this, I couldn't take advantage of this immediate extraction situation. And basically, I have converted it into a delayed case where we have a circular gingival profile and then all the problems associated with using a stock abutment, a narrow stock abutment. But now with these modern protocols, we can place a customized abutment immediately. So we are not loading this. It is just acting like a customized gingival former. But at the same time, it is a permanent abutment. It is a customized abutment which is stocked permanently onto the implant, thereby making one abutment, one-time concept feasible. And then after this, of course, after healing, you see that the gingiva has adapted pretty nicely. And then we find that we give the final restoration, which is having an excellent gingival emergence profile. Another case like this, this is how it looks like. This is how the crown looks, the superstructure fitting looks. So you on the right side, you see all the three components, the tie base, the customized abutment, and the final crown. What tip I wanted to give is the tissue surface of the abutment, which is going to contact the tissue, should be unglazed. So you should leave it unglazed, right? Do not let the lab glaze that gingival portion of the customized abutment. The reason is these surface, the naked surface of lithium disilicate or zirconia is highly favorable for gingival retention, right? So gingival adaptation, so customized hemidesmosomal attachment of providing an excellent inert surface. So another case, immediate extraction, place the implant. We have a customized abutment in place. It is torqued immediately on the day of surgery, then allowed to heal, and then a final crown is eventually placed onto the abutment. So similar situation on a healed socket, a healed implant case. Again, a customized abutment can be given. You need to anesthetize so that the abutment can displace the gingiva and occupy that space, and give it a few weeks, and then you can give final crown. This is particularly useful in an anterior scenario where you have a fractured tooth. I wanted to show you the designing aspect. Maybe we can try. I still have 5 minutes. So you see that this is the tie base situation. Now I want to customize the abutment. So I will modify the gingival emergence margin of the abutment so that we have a nice emergence profile here. And we can actually control the contour of the customized abutment that we want. So sky is the limit. It can be exactly as per your need of the case. Now this has a path of insertion which is going wrong, so it is in red in color. So now I can ensure that the whole palatal hole will emerge somewhere in the palatal or in the palato-incisal region, and then the software will then calculate a full crown first, and then that can be then slowly split into a two-part crown, where one will be an customized abutment and second will be a superstructure. So here we see we have a initial proposal given by the software, and then of course the dentist or the technician will keep on modifying it till it becomes favorable, and make it look like the adjacent teeth. A lot of things can be done. There are a lot of tools which can be used in order to achieve this. So initially, a technician or a dentist would work with a carver on wax. Nowadays, they work with their mouses on the computer, but the skills are similar. it requires actually a little more skill, because it is easier to use your fingers on a wax up rather than use the cursor on your screen, right? So it is a new skill that we acquire, and then once you work at it, it becomes very easy, and thereby. So we have something which is close to what we want, and quickly I'll show you how this file can be split now, and we give the command of split, and the software will then split this entire crown into two parts, one into a customized abutment and second into a superstructure, right? So this is how it looks like. So this is the clinical case where you see the custom abutment made in lithium disilicate in case, and in the bottom you see I gave a temporary crown. This patient was from abroad. She wanted to come back later on and get the final crown done. So this was made in PMMA, milled PMMA. And you see that, she had a trauma because of which she lost the right central incisor, but it had also chipped the left composite filling, which must have been done really long back. So I wanted to close that, close the diastema by doing a composite on the left central incisor and then making a temporary accordingly. But she said that no, I just let the space be. Whatever we need to do, we'll do it later. Then COVID happened, and she came back after 3 or 4 years, and then finally, from here, I could do what I really wanted. So, you can. This was for single restoration. You can use the same concept for posterior teeth or full arch cases also. So this is a case where a welded temporary restoration was given immediately after surgery, and then after the healing period, the patient comes in and we do a quick conversion. We pick up the temporary prosthesis in an impression, send the data to the lab. They scan, they pour a model, they scan the model, they scan the prosthesis and send back the prosthesis, which is fixed back to in the patient's mouth. And then they put tie bases, which are on multi-units on the model, and then scan them. And then we design the prosthesis. So in this case, this was supposed to be a PFM prosthesis, whereby we have the framework here and the final prosthesis, which is ready. And this is now then delivered into a PFM screw-ridden crown. Mind you, this is the same case in which mandibular were purely cemented prostheses, which are more than now 12, 13 or 14 years old. And the maxilla was done after so many years when he lost all the upper teeth. So just to show you the timelines from the upper left, where we started, the lower, which was done immediately, loaded. And finally, on the bottom right, you see the final X-ray. Upper is a screw-retained PFM prosthesis, and the lower is a cement retained PFM prosthesis. Let's see the bone levels; they are absolutely stable. So both work if you do things right and you select the case accordingly. The last, I just want to show you another novel concept, which is phonometrics. I'll just take 2 minutes more. So this is a concept where there is no cement and there is no screw. So the prosthesis uses cement retention instead of cement or screw. The advantage here is you have a good retention with the possibility of retrievability whenever you want, right? So then another advantage, it uses pre-manufactured components. So if you see on the bottom right, you have the standard abutment, which is designed for phonometrics. You have a cap, a phonometric cap, as it is called. As it follows Morse taper 5 to 7 degrees, and it is pre-milled. It is made by the manufacturer, and you just have to tap it in position, and there is a cold welding between the two components, and it gets retained. When you want to remove it, you use a plier or a forceps, wriggle it in the buccolingual or buccopalatal direction, and it becomes loose. So this is a very interesting concept. So whenever we use screw retention, there are always spaces, and the screw undergoes deformation over a period of time and leads to screw loosening and loss of efficiency of the prosthesis. Here on the left, you see the phonometric cap, which is cold welded to the abutment. You can see zero gap. It is absolutely looks as if it is fused together. But that is the beauty of the system. A lot of literature to support it. If you are interested, you can see. So just to end, I'll just show you a case. Full arch case, we extract all teeth, put implant, and achieve relative parallelism between the abutments used for conometric retention. And here you see this is the conometric caps with a antenna on the top, which will be used for intraoral welding. We do welding, and this is how it looks like after welding. We customize a shell converted into a FP3 type of on the same day, and this is the final prosthesis in place, and it is only tapped. So all I need to do is position the prosthesis, use a wooden stick, or there's a appliance also available which is spring loaded. You press the button and it hits the prosthesis on the occlusal surface with the necessary force, or you can just use a mallet and tap it, and that cold weld the prosthesis together. So you have a perfect prosthesis gap-free connection which uses no cement or screw. So the advantage for a prosthodontist is it has no occlusal holes. How good that is, because in all screw retained prostheses we have occlusal holes which distorts the anatomy and sometimes leads to a lot of problems, even breakages, right? So this is for a posterior tooth made in PFM, again using the same concept of conometrics, right? So the conometric abutments in place and it is just tapped into position. That's it. So it is an interesting concept now available with very limited implant systems, but I feel that it might be adopted by other systems as well. So thank you very much for the time that I was allotted, and I hope I could cover in the advantages of using a custom abutment. And I really admire the patience of the audience who have been around for more than three hours now. I thank you, the organizers, for giving me this chance, and we are open for questions. I hope Praveen, you are still around.
Thank you so much, sir. That was a very informative session. We are waiting for questions, though. Is there any? May we proceed? So I would request our Dean sir again to kindly present the e-certificate to Dr. Arya.
Dr. Harshvardhan, thank you so much. Very, very informative lecture, as Dr. Neha pointed it out.
Thank you, sir. Thank you very much.
So let me virtually hand over the...
Received with pleasure and honor. Thank you, sir.
Thank you so much, sir. Thanks a lot.
Thank you, sir. I would like to now invite Dr. Neerja Mahajan to kindly present the vote of thanks.
It's indeed our proud privilege to propose the vote of thanks. We are extremely grateful to our trustee, Dr. Mansukh Bhai Shah, and President Dr. Dikshit Shah for their unwavering support and guidance. Our heartfelt thanks to Honorable Chancellor Dr. Harshad Mehta, Vice Chancellor Dr. Rajesh Bharani, Pro Vice Chancellor Dr. Chandra, Dr. Manoj Kulkarni, and our respected Dean Sir Dr. R.V. Subramaniam for their constant support and enriching learning sessions. Thanks to our Head of Department Dr. Rajesh Seturaman, as well as all the faculty, postgraduate students for working as team and making the program a success. Special thanks to the IT team, and last but not the time, and joining us today. Thank you so much. The IT team and
Thank you so much, everyone. We thank you for your patience. Thank you for joining us today. Thank you so much. Thank you, Dr. Arya. Thank you. Thank you, sir. With that, may we end the meeting? Thank you, sir.
Thank you. Thank you all. Thank you so much.
Thank you, sir. Thank you.